Hello, hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, December 15th, and time for a regularly scheduled IC and pelvic pain support group meeting. Hello from Northern California, where fire season is over. Praise God, hallelujah. We have blue sky outside, but we have had 5 days or 10 days of rain, and we can finally breathe again. Woohoo, Betty. So, here, hold on a sec. I'm getting my computer set up. I had somebody unexpected drop by. All right, my friends. So, my name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. I am the longest serving interstitial cystitis support group leader in the United States, 26 years and counting. Next year will be my 27th year. Hello, Cher. Hi, Kristen. Hi, Heather. Hi, Beatrix. Hello, Donna. How are you today? My purpose in doing these international meetings, and we simulcast on Facebook and YouTube. So if I'm looking up here, I'm looking at Facebook. If I'm looking down here, I'm looking at YouTube. My purpose is to make you so strong, so knowledgeable, so incredibly informed that no one can mess with you ever again. Nobody, especially now that we're going through this holiday season, I want you to be so incredibly armed whenever you walk into a family meeting and a family event that no one can mess with you, right? So you're going to be strong. You're going to be knowledgeable. We're going to talk to you about how to talk about IC when other people don't believe that it's real. The many different variations of IC, how self-help is important, how diet is important. You know, you are not alone, my friends. You are absolutely not alone in this struggle. And rather than trying to recreate the wheel and do it at home and face the holidays, not knowing what to say and dreading seeing people, we're here to help you. I'm here to help you. And one of the cool things about being online here is that y'all help each other too. And that's one of the cool things about simulcasting both on Facebook and YouTube is the support and encouragement you offer to each other. Gosh, it's just absolutely inspirational to me. Absolutely inspirational. So I hope that you get some value out of this meeting, that you get some support out of this meeting, that you get some comfort out of this meeting, and you get some good ammunition that you can use with anybody who might be treating you incorrectly. And that includes doctors too. You know, I always tell patients whenever you go to the doctor for the first time, whenever you go to the doctor for a second opinion, I never, ever, ever want you to walk in and say, "Hey, I've got IC. Can you help me?" That does not get you anywhere where you need to go. Instead, what you need to do is you need to walk into a doctor's office and be very crystal clear about your symptoms. What are your symptoms? So that you can get him or her to focus on your anatomy, your unique anatomy, because every IC patient is an anatomical mystery to be solved. And we've got to figure out what in your pelvis could be triggering your symptoms. Could be your bladder? Yes, it could be. But it could also be your pelvic floor. It could also be a fibroid tumor pushing on your bladder. It could be a nerve injury. There could be some genetics involved. There's lots and lots of different things that we know can contribute to IC symptoms of frequency, urgency, pressure, pain. I'm also going to say, and it's important to, to think about this over and over and over again, is back in the old days, now realize interstitial cystitis was first written about in a medical journal in the mid 1800s in England. All right. And if you were to read that original case study of an IC patient in England, it is perfect for today. This patient had unexplained frequency, could not sleep through the night. They had sudden moments of urgency. They had pain as their bladder filled with urine. You know, think about it. They had this documented around 1850. And when the cystoscope was first invented back in the early 1900s, they could look in the bladder. And in fact, that's when they found the Hunner's lesions. And that's when they found a very, very badly irritated bladder wall. And all through this point, all the way up through World War II, everybody was going, okay, this is a structural issue. We see issues going on in the bladder. But then in the 1950s, two egocentric idiots of doctors published a case study in which They suggested that a woman in their clinic had, quote, unexpressed anger manifested in the pelvis, and they claimed that she had a psychiatric disorder. Of course, she didn't, but they claim that. And so, from about 1952 to 1987, medical schools often taught that this was not a real condition. Now, of course, we've learned a lot since then. Number one, the US government, the National Institutes of Health, has spent $100 million studying IC. They would not have spent $100 million on bladder research and pelvic research if it was not a real condition. This is absolutely a real condition. There's no doubt about that. But again, when you walk into a doctor's office, you got to understand that every medical school teaches differently. And we don't want you to fall down the rabbit hole of a doctor suggesting that this could be all in your head, because it's not. Okay, absolutely not. And again, the $100 million in research proves that. But the so even up to that point, like 1987, 1990s, all the way up through 2008, everybody was then, we'd gone back to, okay, this is a bladder disease. And the assumption back then was this was, quote unquote, an incurable bladder disease. But then something miraculous happened in 2008. In 2008, the National Institutes of Health released their first multi-center study of pelvic floor physical therapy. Because again, if you go back into the early documentation, 100 years ago, doctors are describing muscles so tight in patients that they resemble tight piano strings. And so all along this time, everybody was going, tight muscles, tight muscles. We see tight muscles. They feel like piano strings. They're so tight. And yet getting doctors and clinicians to look beyond the bladder at the muscles was very, very difficult. But finally, in about 2006, 2007, started happening. And finally, in 2008, the National Institutes of Health released the results of the first clinical trial with pelvic floor physical therapy. And guess what, my friends? Guess what? It worked. The pelvic floor physical therapy outperformed virtually every other therapy ever studied for IC. And think about it. Wait a second. Wait. If IC were exclusively a bladder disease, why would pelvic floor physical therapy help? Why would it help? Makes no sense, right? And it was at that moment that the IC world changed. We were put on our head, because at that point in time, everybody then had to go, wait a second. What is the rule of medicine? Do no harm. And the rule of medicine is try to make people feel better. And it was an undeniable fact that patients felt better when they did pelvic floor physical therapy. So everyone was kind of forced to take a step back and go, wait a second. If pelvic floor physical therapy and manipulation of the pelvic floor muscles made somebody's bladder symptoms improved, maybe it's not exclusively a bladder disease. Maybe the muscles are involved. Woohoo, look at that. And you know what? They were right. Because once doctors started assessing for pelvic floor dysfunction and providing proper therapy for pelvic floor tension, the world changed for the better. Now, since that time, 2008, a new thing happened in the IC world. And that is, once the closed-minded people were forced to open their minds and consider the muscles, people started looking at and considering other factors. It's like, okay, so we know there's two groups. We know there's bladder, we know there's pelvic floor. But then when we look at the bladder, it's like, well, wait a second, we got a couple of groups in there. We know we got Hunner's lesions versus non-Hunner's lesions. And then, of course, we've got symptoms. We've got patients who have other pain conditions, like IBS. Not everybody has other pain conditions, but a group of patients do. And some patients clearly have nerve injuries. And then we got next generation urine testing, which allowed us to do DNA studies of bacteria. And that then helped us see, oh, you know what? urine is not sterile, that there's a lot of bacteria that live in the bladder, a lot of fungi that live in the bladder, a lot of viruses that live in the bladder. So then we thought, oh, look at that. Look at all the variation just in the bladder itself. So, really, for the last 10 years, what all the top clinicians are doing is something called subtyping. But they're all trying to create their own perfect subtyping system. So, Europe has its own system, Canada has its own system, Japan has its own system, and in the United States, we don't have a nationally agreed upon subtyping system, but I use a system that was created by Dr. Christopher Payne, who ran the IC research program at Stanford University. And one of the things he remarked in his proposal is I mean, it was a really provocative article, and I'll link it on our website. You can go find it on our website. And you know what, guys? I haven't drunk a lot of water yet today. Hold on, let me take a deep breath. Hold on. This is pumpkin spice rooibos tea, bladder friendly. Okay, so one of the things he said in his article when he proposed his subtypes is he said, we should treat IC patients like cancer patients. And I'm like reading this going, why the hell would you even talk about cancer and scare people? And his answer is, well, there's no comparison. IC is not cancer. But I want you to think about it in a different way. When someone is diagnosed with with cancer, they're not just told they have cancer. They're told that they have cancer of the left breast that is estrogen dependent type 1, 2, 3, right? And when someone is diagnosed with cancer, like me a couple years ago, in fact, I just had a breast cancer scare, literally right before Thanksgiving, like, holy hell. Um, uh, um, they give you such a specific diagnosis that you and the doctor know exactly what to do next. Like for me, with what they thought was early uterine cancer, is hysterectomy. We knew what to do. And he argues very, very successfully that a diagnosis of IC does not tell you, the patient, or even the clinician, what your next step should be. It does not give you an intuitive treatment pathway. So, how do we get there? How do we get there? And that is with, as he argues, specificity. The way we're going to give you an intuitive treatment pathway that will focus on your unique presentation of symptoms is by giving you a more individualized diagnosis. And that is through the form of subtypes. And he proposed 5 core variants of IC. So hold on a sec. Let me, I kind of like never know how I'm going to start these meetings. So I was going to go in a completely different direction, but then I started talking and bam, there you go, subtypes. So Dr. Christopher Payne, when he proposed his 5 fundamental variants of IC, one of the other things he said in his article is how unfair it is to tell patients this is incurable, because some of these subtypes are curable. Some of these subtypes are curable. So again, it's about specificity. And you can see that specificity in your groups, because all you need to do is ask your friends, how did their symptoms begin? For some people, IC begins in childhood. For others, after menopause. For some, IC begins after having a baby. While for others, IC begins after chemotherapy. For some, it begins after a traumatic accident. For others, it might begin after, I don't know. I mean, it can be any sort of trauma. And all you have to do is look at the variation of the triggers of these symptoms, as well as the variation of the patient's, a variation in how their symptoms began, as well as their different presentation of symptoms, to really understand and see the rich diversity in this patient population. And what do we also know too? A one treatment fits all approach does not work. Period. Doesn't work. So Dr. Christopher Payne said, hey man, we got 5 core variants of IC. So here we go. He's now at Vista Urology. You can go over to his website, learn more about him. He's the top pelvic pain center on the West Coast here in the United States. He says IC subtype 1 is Hunner's lesions. Everybody in the world agrees with this. Everybody in the world agrees that Hunner's lesion patients are a unique population in the IC patient community. And in fact, many people believe that it is its own unique disease. In fact, at the European Society for the Study of IC meeting 10 days ago, they again talked about how important it is to consider Hunner's lesions unique. Why do we say that? Because when those lesions are biopsied, we find massive inflammation, unlike all the other subtypes. Now, this is only 5 to 10% of the patient population. But if you've got Hunner's lesions, then you've got to come on over to our website, which is icnetwork.org, and read about it, because Hunner's lesions don't respond to traditional medication. Hunner's lesions require lesion-specific therapy, and I'll get into those if somebody asks. IC subtype 2 is bladder wall driven. So these are the patients who have a legitimate bladder disorder. No doubt about it. So the question is, what the hell's going on with the bladder? Well, the bladder, like any other part of the body, can be injured. And how is it usually injured? It's usually injured through some sort of chemical exposure. And so this is where we see the chemocystitis patients, patients who develop symptoms because they've gone through chemotherapy. We also see this with radiation cystitis, although radiation cystitis actually doesn't damage the bladder wall as much as it damages blood vessels. We see this in patients who have a terrible diet. And they're not drinking any water, not understanding that super concentrated urine is irritating, especially urine filled with acid, right? And so the bladder, like any other part of the body, can be injured. It's also important to understand that the bladder only knows one language: frequency, urgency, pressure, pain, right? The only way it can tell you that there's a problem is by giving you symptoms of frequency, urgency, pressure, pain. And so you can assume, because you associate those symptoms with infection, many patients assume it's infection over and over and over and over again, and you keep self-medicating yourself with antibiotics. Well, if you could have a bullet wound and it would feel like an infection, you could have a stab wound and it would feel like infection. The only way that the bladder can tell you it's hurt is through frequency, urgency, pressure, pain. And that is why having good urine testing is important. It's important to not guess. We need facts. We need facts. So in this category, we're also going to look at acute infection, but we're going to look at chronic infection. Could you have a chronic bacterial infection? Or could you have a chronic fungal infection? I just got off the phone with somebody who's currently in this meeting right now, who is struggling with terrible, terrible vaginal and bladder issues. And they discovered that she had a drug-resistant Candida glabrata infection. And when they actually were able to kill the Candida, her bladder symptoms improved massively. And the National Institutes of Health confirmed that. The National Institutes of Health has found that many patients struggling with flares actually, in some cases, have fungal infections, yeast infections, candida infections. And the question is why? And I think we got two reasons. Number one, we often take a hell of a lot of antibiotics unnecessarily, creating the perfect environment for yeast to grow. And also our IC-friendly diet tends to be kind of high in sugar, which of course feeds yeast, right? Okay, so IC subtype 2, bladder wall driven. IC subtype 3, pelvic floor driven. This is the biggest subtype right here, my friends. These are the patients whose symptoms begin after some sort of muscle trauma, a car accident, a fall. Man, I've been talking with a lot of people who have fallen on their tailbones and have tailbone injuries that were the triggering factor for all of their pelvic issues and bladder issues. But these are also the patients who had symptoms after they have a baby, or if they had a history of sexual abuse, or if they were an athlete, if they were a gymnast or an ice skater where there were repeated pelvic traumas, football player, paratrooper, worked with all of those patients. So the cool thing about this one is that this is treatable and potentially curable with muscle work. Now, of course, a lot of people don't quite get the muscle work. Oh my God. Oops, hold on. How's the sound? I hope the sound was okay. You guys, how's the sound? I hate it when I do that. Here, hold on a sec. Hold on. Hi, Rhonda. Hi, Harriet. Hi, Sue. Hi, Tracy. Hi, Sherry. Hi, Dina. Hi, Curtis. Hi, Brock. Dagmara, that's a great question. Is it possible is it the hormones are responsible for flare-ups? Absolutely. Yeah, that's normal. Completely normal for a patient to flare them the day that they ovulate and or a day or two before their period starts for women. Completely normal. Okay. I see subtype 4 pudendal neuralgia. So these are the patients whose symptoms begin after some sort of nerve trauma. And in these patients' cases, they don't in addition to perhaps having some frequency urgency, their symptoms are very positional in nature. They're fine when they stand, but when they sit down, it hurts, or when they bend over, it hurts. And they have a nerve-driven pain, neurologically driven pain. Like for me, earlier this year, I had a prickling sensation along the outside of my vulva. Made no sense. And we were actually able over a period of months to rule out lots of other stuff. And it then became the pelvic pain specialist was like, this is pudendal neuralgia from tight muscles. So again, I went into pelvic floor physical therapy. It turned it off. Okay. So nerve pain can do all sorts of interesting things, but it tends to be very positional. And then I see subtype 5 is central sensitization. This is the inherited subtype. These are the patients who have extremely sensitive skin. We tend to be drug sensitive. We have a wicked sense of smell, all sorts of things like that. And those are all signs that our body is hardwired to be a bit more sensitive, more easily to stimulate and turn on. So we have sensitive skin, we've got a sensitive stomach, we've got a sensitive gut, we've got a sensitive bladder. Hello, Andrea. So anyway, kind of rambling today. Sorry about that. Don't really normally ramble like this. But my point here is again, as you go into your holiday gatherings here, and as you're dealing with people who are asking questions about IC, I really want you to talk about it as more of a pelvic pain syndrome. I want you to talk about the variations, and I don't want you to apologize. I don't want you to defend yourself. I want you to educate. I want you to educate others about this. There are people out there right now and I'll tell you right now, a lot of guys who have been diagnosed with prostatitis who actually have pelvic floor muscle injuries. So talking to people and educating people about the role that the muscles play in bladder health and pelvic health is important. Understanding the differences between Hunter's lesions versus bladder wall injury. If you've got a family member who is massively addicted to soda and they're up peeing all night, you can explain, hey, you know what? Listen, the bladder was designed for life 5,000 years ago when there wasn't a lot of acid. You are exceeding the ability of your bladder to defend itself if you're drinking acid all day. And eventually that acid's going to take a toll in frequency, urgency, pressure, pain. So anyway, all right. I have my whole thing set up and then different things happened. So normally when I do these meetings, I do about 30 minutes of lecture. You just got 20 minutes of that. I will take questions for about 2 hours. Then I do a free giveaway. I need to take a moment and thank our sponsor, Prelief. Prelief is the oldest. Ow! Ooh, sorry, that's my knee. Prelief is the most popular supplement ever used by IC patients. It's been around for probably about 30 years. It is an acid-reducing product. So if you've got to go to grandma's house and eat her lasagna, and you're worried that that's going to kill your bladder or kill your stomach if you've got a sensitive stomach, you can use something like Prelief, which is a calcium pill that will reduce the acid so it's not so irritating. The same would be true with Tums, something like that. So make sure you stock up on a little bit of Prelief before the holidays because it actually might help you. One of the things I always like to say about Prelief is, listen, it's not candy. You don't take it all day, every day. It's not a treatment in the sense that it doesn't do anything biologically beneficial to your bladder wall. It just reduces acid. But that calcium has to go somewhere. And if you're taking a lot of it, your body's got to get rid of that calcium, and you can get excess calcium in your bloodstream and or kidney stones. So again, you don't take 20 a day. You take 1 or 2 before a meal. Give it a shot, talk to your doctor, see what your doctor might have to say. All right? But Prelief is out there. Now, gosh, I got good news and I got bad news. What do we need to talk about at first? I did a big support group meeting this week, and where I first talked about the really, really, really sad news that happened. So let's do that first. Because as I put in my intro, we did get new Elmiron IC research, and it is pretty devastating. Pretty devastating. So let me just give you a lead up to the newest research. So most of you know that Elmiron is the only approved oral medication for interstitial cystitis, approved by the US FDA in 1996. And of course, using the subtyping system that I just talked about, Elmiron really applies to IC subtype 2 bladder wall driven. Elmiron's not going to help the pelvic floor. It's not going to help a nerve. It's just not. Elmiron is good for genitourinary syndrome of menopause. If you've got estrogen atrophy in your bladder, it could be appropriate there. So many, probably a couple 100,000 patients or more have used Elmiron over the years, and it's always considered pretty safe. Um, um, One of the challenges of Elmiron is something called bioavailability, and that is Elmiron acts as a chemical band-aid, right? So if you swallowed a band-aid, would you expect it to come out the other end of band-aid? And the answer is no, it's affected by digestion. And so of the Elmiron that you're taking, 93% of it is rendered inactive by digestion. It's destroyed. So really only 5-6% arrives in the bladder to be beneficial. And some people, even I just talked to a doctor earlier this year who was saying he thought it was about 3%. And so because of that very, very poor bioavailability, you've got to take a lot of Elmiron over time for it to be helpful. But of course, when you take a lot of it over time, there are side effects. So the classic side effect of Elmiron is going to be hair loss, upset stomach, diarrhea, easy bruising. And now we know, thanks to the work done by some eye specialists at Emory University that was released last year, Elmiron patients also appear to be at risk for retinal disease, eye disease. Eye specialists in general, ophthalmologists, especially at a university, they're there to solve the mystery of why a patient is having unusual vision symptoms. And their job is to go through genetics. They just like a diagnosis of IC, they've got to rule out everything. So they had a pretty sizable population of IC patients come to their clinic, although they didn't recognize that they were really IC patients. These were patients who were presenting with unusual vision symptoms. And those symptoms were blurry vision, difficulty reading, and especially difficult night vision or transitioning from light to dark or dark to light. And as they were studying this group of patients, again, they really couldn't find any normal cause until they looked at the medications they were using. And what they found was that these patients were using Elmiron and had used Elmiron, pentosan polysulfate, for many, many years. So they came to believe that they had discovered a new retinal disease associated with the use of Elmiron. And they published those findings in a journal article in the journal Ophthalmology in the spring of 2018. And look, here is that article. Pigmentary maculopathy associated with chronic exposure to pentosan. And this is what we call a case series. It's a series of basically the stories, examination results of 6 patients. They're not making any statements about population. They're not saying, hey, every patient has this. The purpose of this is to show other ophthalmologists the damage that they're observing. Okay. And you guys hold your questions. I promise you, I will get to your questions. You gotta let me do my thing first. So 6 patients in this. I used it on average of 15 years. However, the worst patient in the study was the youngest patient in the study who had her eye damage appear after 6 years. of use. And she actually is a patient who has the worst damage. And she's actually been to some of our support group meetings. She might even be in here right now. I don't know if she is. But let me just show you some pictures so that you can see what they were finding. So this is kind of a time series. So this is at the first appointment, this is at the second appointment, and this is at the third or fourth appointment, right? So you can see whatever is happening is here is getting worse, right? One of the really important parts of this paper is that they went back into the history of Elmiron. And I'll tell you here, I mean, I will tell you, as a support group leader for 26 years, up to this point, nobody's ever talked about eye issues with Elmiron, ever. And so, I mean, within any support setting, with any lectures, anything at all like that, it was never discussed. They found a clinical trial that led to the approval of Elmiron before 1996. And these patients took 22,499 patients, received Elmiron for up to 4 years, and vision-related adverse events were reported. Optic neuritis, amblyopia, and retinal hemorrhage. So we know, based upon that study, that the company that invented Elmiron, the people who invented Elmiron, knew that they had eye issues. What's interesting is that they didn't really talk about them to other people. I mean, they were never, if you look at the early Elmiron educational materials, you don't see any discussion of eye issues in any of the patient brochures. Like here's an example of an old Elmiron brochure, right? And when they talk about eye issues, I mean, they don't talk about eye issues. When they talk about side effects, they say the most common side effects are hair loss, diarrhea, nausea, blood in the stool, headache, rash, upset stomach, abnormal liver function tests, dizziness, and bruising. No discussion of eye issues, right? And yet, in this paper, these researchers at Emory found eye issues in an early clinical trial. Now, of course, here's the problem. Urologists don't read ophthalmology journals. They barely have time to read urology journals. So here they are in Emory going, how do we let people know? How do we let the urology community know, the IC community know, that we think there's a problem with Elmiron use? So what they did is they sent a letter to the editor to the Journal of Urology, and that was we first saw it over Labor Day last year, in which they were trying to bring attention to these unusual eye symptoms to the urology community. And most importantly, in that paper, aside from describing what they were seeing, is they made a very strong recommendation that patients should stop the medication and have eye exams if they're showing any eye issues, if they're showing any eye issues at all. That's a real take home from this, is if a patient has used Elmiron for a period of time and you got any sort of vision changes, you got to get to an eye doctor really, really quickly and have them check your retina. Just make sure nothing is weird is going on with your retina. Now, of course, I don't read ophthalmology journals, so I found this over Labor Day last year, and I'm like going, "Oh my God, no!" You know, tears rolling down my face, thinking that this could be happening to IC patients. So I sent the article to my medical board and to anybody that I could think of in leadership positions and asked for their feedback. And then I got some help from Robert Moldwin and designed a research study just to kind of credibility test it. So we did a survey, and that survey now has 1,600 patients who have participated in it, Elmiron users. 53.7%, somewhere in there, report that they have retinal issues. So our survey, within a week, we had 700 or 800 patients, showed that there was validity to this study and we needed more research, right? Now, of course, other people discounted this. They were like, come on, it's a case series, it's 6 people, it's not consistent. You know, it's nothing to get worried about, yada, yada, yada. And what, again, both patient groups and physicians were forgetting the purpose of that case series, and that was just to define the damage, to show the damage, to let other ophthalmologists around the country and around the world know that they've seen this. And interestingly, other ophthalmologists around the world started paying attention to it. And in fact, an ophthalmologist here in Northern California, now Emory is in Atlanta, an ophthalmologist here in California went, huh, let me go back through our patient records. Let me see if I can find patients using Elmiron and let's study their eyes. And they did the first clinical population-based study that was released this fall. They found in this one clinic 140 patients who were currently using Elmiron and had used it for a minimum of 5 years. They asked them if they would come in for eye exams. 91 agreed to come in for eye exams. And what they found is 24% of those patients had this eye issue. They showed signs of pigmentary maculopathy from Elmiron use. So now we've gone from 6 patients to, in one clinic, 24% of Elmiron users are showing signs of eye issues. Okay. So again, we passed the point where this is a little thing. We are now at the point where this is becoming a very, very big thing. And now that this information has been out and patients have been going to the doctor, and quite a few of you are now patients at Emory, it's very clear that this is a devastating side effect from Elmiron use. And many of you know that we were asked to submit our data from our study to the FDA, which I did a year ago. I'm going to do it again. And the purpose of that was to try to get the FDA to request a labeling change so that the label from Elmiron would say annual eye exams strongly suggested, or if you show any eye issues, to go do that. Okay, Kel, I see your question, but I'm going to keep going with this and I'll come back. I promise you guys, I will come back with your questions. Okay, so now we have our first population-based study, 24%, or clinical populations, a clinical subset of 24%. Many of you have also already seen ads circulating through social networking of attorneys now looking for patients to participate in clinical trials. So I was last week doing an updated newsletter, which I still haven't sent out. I didn't want to send it out this weekend. I'll probably send it out tonight to everybody who participated in our Elmiron study, given the update. And as I was writing this, I thought, well, I better go look and see if anything else popped up. And so I went to the National Library of Medicine, and guess what? New Elmiron study, this time from Harvard. And this is not good. It's devastating, in my opinion. So, an ophthalmologist at Harvard Medical School saw the article in Ophthalmology and thought of a patient that they had who had unexplained eye issues. And so here we've got a 62-year-old woman who 8 years ago goes to Harvard because their vision is changing dramatically. And Harvard does the first examination, and they definitely show signs of retinal atrophy, changes in the retina. And by the way, here's the article. This is the article that just came out, Progressive Maculopathy After Discontinuation of Pentosan. Okay. So let me give you the context here. 62-year-old, difficulty seeing with her left eye specifically for a year. They look at everything. They see no genetics at risk. They have no explanation as to why her retinas are changing. And interestingly, they think, quote, the findings raise suspicion for a toxic etiology, but there was no history of exposure to known retinotoxic agents. So they thought when they first saw her at Harvard that she'd been exposed to something that had damaged her eyes, some sort of toxic chemical. 6 years later, she returned again at the age of 67, and her vision had worsened in both eyes. And again, they rule out all genetics, they rule everything out, and there's no explanation. They just simply do not understand why her eyes and her retinas are changing so badly. 2 years later, she comes back and her eyes are even worse. And so let me show you the pictures here. So we've got left eye, right eye. Okay. So the top series is the first appointment, right? The first year. So you can definitely see this is her left eye, that there are 3 large spots in her left eye, in her right eye too. And these are different types of eye tests. And then this is at year 6, and then this is at year 8. And you can see, look at the progression here. Here you can see kind of individual spots. Now it's just one giant lump of atrophy in the retina, or a change in the retina. And again, this ophthalmologist at Harvard is baffled. They have really no idea how and why she has this profound eye damage. So they send her on her way, with as much help as they can do. Hi, Alan. And then the article in Ophthalmology comes out, right? This article came out last year. And that ophthalmologist, to her credit, went, let's pull up her case again. Guess what? She was an IC patient. Guess what? She'd taken Elmiron for 18 years. 18 years. She took a low dose of Elmiron, just 200 milligrams a day, but she'd definitely taken Elmiron for a long period of time. And when they compared her pictures with let's see, with these pictures, right? Can I do that, right? They look very similar. What's interesting about the Harvard study is another set of, I think this is a far more meaningful picture. This is called a serial optical coherence tomography imaging, where it's really a three-dimensional picture of the retina. So look at this. First year, 6 years later, 8 years after that, and you can see the cells in the retina changing, right? Look at that. Really profound changes in this one patient. And again, going back to this original paper, they had the same thing. They were showing these changes here. So again, the Harvard researchers really felt like, okay, this patient matches all the information we have on pigmentary maculopathy caused by Elmiron. This is indeed a patient, we think, who has this side effect from Elmiron use. Remember, they saw her at 62, 68, let's see, 62, 68, and 70. So we're in there, right? Here's the problem. She'd stopped Elmiron use at the age of 63. But her eye symptoms continued to get worse and continue to get worse. And they made a point of comparing this to a drug called Plaquenil, which is called hydroxychloroquine. Plaquenil, which is used to treat malaria and is actually also used for fibromyalgia and some conditions like that, has been proven to cause eye damage. And in Plaquenil, they have also determined that when you stop the Plaquenil, the eye damage continues to worsen. Devastating. And they believe that this is what is happening in this patient. They believe that this patient is experiencing progressive, long-term eye damage from Elmiron use after stopping the medication. Oh, my friends, I agonized over how to share this, because I believe that every patient has the right to informed consent, that you deserve the full information so that you can make good, educated decisions about your medication use. And this is big. I mean, if you're picking, let's take two medications that are commonly used with IC: amitriptyline and Elmiron. So what we know with amitriptyline for some people is that amitriptyline can cause weight gain. I gained 20 pounds on amitriptyline, easy. Amitriptyline can make your heart race, right? So if you have a heart issue, you know you're not going to take amitriptyline, which is why I stopped it. So here we got, you get to choose. Do I take a medication that can make me gain weight? Or, do I take a medication that could make me blind? That could damage my eyesight so badly I might not be able to read. And you, as the patient, should have access to all of that information so that you can assess the pros and cons of risk versus benefits. Now, I sent it all to, again, my medical board again, because I was reading this last, oh God, what day was it? Last Friday. These are the moments that you hate, because you've got to make I had to make a big ethical decision about, do I share it or do I not share it? Do I share it and scare people? Or do I share it and empower people so that they know what's going on, and perhaps reconsider using it potentially? Of course, with a good, thorough discussion with your doctor. And in the end, I realized that if I sat on this information and a year later we had another study come out supporting this, some people were going to go, Jill, you knew about this a year ago and you didn't tell us? I could have stopped it a freaking year ago if you told us a year ago. I had all this going through my brain going, okay, this is not the type of information you sit on, but it's also the type of information you've got to deliver very, very gently. Now, again, this is just a case study. This isn't, this is one report, but the source of the report is impeccable. Harvard Medical School. Doesn't get any more credible than that. I emailed Dr. Jane, the guy from Emory who did the research, and I said, can you tell me a little bit, can you tell me more about this? And he goes, Jill, this is real. This is deeply, deeply concerning. And he shared that, again, because some of you attended my lecture a year ago on this, are now part of his study where they're following patients over time to see what's happening with their damage with their eyes while they're taking the medication and after they stop it. So he's just finishing up that year's worth of study, and he said early in 2020 we will have his data for it. Okay, so you can go back and you can watch my I did a live stream on this on Tuesday or Wednesday. You can watch that too. I talk a little bit more about it. I'm a little scattered today. I'm not talking about it as well as I was talking about it a couple days ago. Didn't sleep as well last night. I think it's deeply, deeply concerning. I have already suggested, in my opinion, Elmiron should be removed from step 2 as a treatment option for IC in the AUA guidelines and put into step 4 or step 5. The AUA guidelines, that 6-step treatment protocol where you start at step 1, you do everything in step 1 before you go to step 2, you do everything in step 2 before you go to step 3, and so forth. They're ranged with respect to the risk of adverse events. So the AUA wants you to do the easy stuff before you do the hard stuff. And they have Elmiron in step 2. And they also have amitriptyline in step 2. And they've got Atarax in step 2. What do we also know from this year? That the amitriptyline and Detrol and Ditropan, the antispasmodics, have now been linked to dementia. And so this summer, I sent an email to them and said, I think these medications need to be removed from step 2 and put into step 4 or step 5. Because in step 4 is Botox, and Botox is reversible. If you have a side effect from Botox, when the Botox wears off, you normally go back to normal. Whereas with Elmiron, if you've got eye damage, that eye damage appears to be permanent and potentially progressive. And so I think you would support me in moving it from step 2 to step 4 or step 5. And I hope that they will do that. We also have to energize our FDA campaign to get them to change the label of Elmiron to strongly suggest eye examinations every year. Now, if you're on my mailing list already for this, one of the things that I say in there is you're going to know about this before your eye doctors will. I mean, before your urologist will. Okay, why? Because urologists don't read eye journals. They just don't. So when you get that email and you print out that email, you need to understand that when you deliver it to your urologist, they're going to go, I don't know. I don't know. And the answer is they don't know. It's the eye doctors who know. Amazingly, Elmiron was just approved as an IC therapy in Scotland. Like, what the hell? Wait. Have you considered any of the eye issues with this? And at this point, we don't know if they have or not. So, if you're so here's your take-home message. If you're currently taking Elmiron and it's helping you, power to you. I'm happy that it's helping you. But you got to be knowledgeable and informed. You got to get your eyes checked every year and get your eyes checked as soon as you show any eye issues. Quite a few people have already stopped using Elmiron or reduced their dosage of Elmiron because they are worried about the eye issues, or they already have a genetic predisposition towards macular degeneration and they don't want to double their risk. So the question then is, what do you do? A far safer way of using a chemical Band-Aid bladder coating is to put it directly in your bladder. Don't swallow it first. When you swallow a Band-Aid, it gets, it's broken down into its byproducts or active ingredients or whatever, ends up in your bloodstream. It is circulated throughout your body. Clearly, part of it arrives by the retina. They don't know exactly how that damage is happening, but that's the assumption, is that the Elmiron is somehow building up on the retina in some way. That's kind of the active guess right now as to why this is happening. And of course, some of it then arrives in your bladder. Again, 5 to 8% of it. But, if you use an Elmiron bladder installation where you're not swallowing it and 100% of the medication arrives in your bladder to do what it needs to do, be a bladder coating, that is a much better way to use medications like this that have side effects, because the odds of it getting into your bloodstream to any significant degree are substantially lower than taking it by mouth. So for that patient who doesn't know what to do, you could consider Elmiron installations instead, or you can consider supplements, because we now have supplements that contain chondroitin that have been found to be quite helpful for patients who need that coating effect but cannot afford Elmiron or cannot tolerate Elmiron. And the supplements are, let's see. Oh, here we go. So the supplements, the more common supplements that are used are going to be bladder builder for a coating effect, bladder rest for a coating effect, cystoprotect for a coating effect, or cystorenew for a coating effect. Cystoprotect, I have been told now we will have, I think they said on the 23rd, right before Christmas, which means we won't be able to ship it probably until after the new year. But anyway, the new reformulated Cystoprotect without the titanium dioxide will be available again soon. So, if you're uncomfortable with the Elmiron, you got to go have a discussion with your doctor about the risks, the pros and cons, and just know that there are other coating type products that might be as helpful, if not more helpful, than the Elmiron. Okay. Now listen, I'm not here to give you medical advice. I'm not here to tell you to stop the medication. That's not my job. My job is to give you the information, kick you in the butt, get you back to your doctor so you can have a discussion with your doctor about what your options are. Okay. Now, Becky says here, hold on a sec. Becky says, where is bladder rest available? It's available on Amazon and it's available in the ICN shop. I will tell you in the ICN shop, it's $10 cheaper. So if you go over to icnetwork.org and you click on our store, you can get it for $39. If you buy it on Amazon, it's going to be like $49, somewhere in there. And that's just because that's the money that Amazon adds to it. That's Amazon share. That's why. So bladder builder, or bladder rest, or Cysto Renew. Where's my bottle of Cysto Renew? Where's my bottle of Cysto Renew? Let's see. Everybody. Weird. You can see it. You can see it over on our website. And then of course the Cysto Protect. Cysto Protect was by far the top supplement until it came out with a cancer warning for titanium dioxide last spring. Pretty much destroyed it. But they have, after 9 months, reformulated it to take out that one ingredient, so it will no longer have a cancer warning on it again. So that's good. Krista says, I'm new to this site and newly diagnosed. Where's the best place for me to start? Presently waiting for an MRI. I have a fibroid tumor along with the ICBPS. So, Krista, the really cool news here is that once that fibroid tumor is treated, especially if that fibroid tumor is pushing on your bladder, we have research that shows that like 65% or more of patients with fibroids who experience frequency urgency, that their urinary symptoms disappear completely and they are cured once that fibroid is treated. But over on our website, if you go to, icnetwork.org, I want you to go to our Living with IC video series, and I want you to watch 3 videos: the 5 subtypes of IC, the 6 steps of treatment, and the estrogen chat. Those are the first 3 videos to start with. And then you can read through the rest of the website after that, but start with those videos first. Okay, so you guys just know that unfortunately Facebook doesn't let me scroll back. So if you asked a question on Facebook that I missed, please ask it again. Don't take it personally if I don't answer your question right away, because questions scroll through really, really quickly. And I can only see 3 comments at a time before it passes. Danielle says, my pelvic pain specialist says Elmiron has never really helped my patients, any of his patients. Yeah, I mean, Elmiron fell out of favor years ago. Years ago. And the kind of the nail in the coffin of Elmiron was when it went off a patent and the company raised the price dramatically because they thought a generic was going to come out. So Elmiron went from being like $250 a prescription to $2,000 a prescription for some people, and people just couldn't pay for it. And now with the eye issue, we can be thankful that they did that, because that meant a lot of patients aren't exposed to the damage. Lily says, my doctor has never been convinced by Elmiron and refuses to prescribe it. You know, it's funny, when it came out in 1996, I wasn't convinced by it either. I mean, I have a degree in drug development, pharmacology, drug development, and I don't know, man. I looked at it and I just went, I'm not taking this. I don't know. There was just something about it back then that just didn't resonate with me. Rebecca is bringing up the role on Facebook of chronic UTI. And again, we go through this with every meeting. Again, there's tremendous diversity in this IC patient population. So we've got Hunner's lesions, which have been connected now with viral infections. We've got bladder wall, we've got muscle, we've got nerve, and we've got central sensitization. I cannot, and I do not believe in making any broad strokes saying everybody has infection or whatever, whatever. It doesn't apply. If you're a support group leader, you work with patients every day like I do, you know that that is patently incorrect. However, in IC subtype 2 bladder wall driven, there are variations in that subtype. So we've got genitourinary syndrome of menopause in that subtype. We've got chemical irritation in that subtype. And we've got acute infection and chronic infection. And there is a subset of patients who clearly have chronic infection. They've got a deep fastidious infection in their bladder wall that is resistant to therapy. And they require more expensive antibiotic therapy. But it's a hot button. It's very, very controversial right now because what do we know? Antibiotic resistant infections are exponentially growing. They're killing people every day in hospitals. Antibiotic resistance is driven by the overuse of antibiotics, and both in people and in animals and in food, in the food supply. And thus, what you see is a concept called antibiotic stewardship. There's a massive effort now to pull way back on long-term antibiotic use or antibiotic use at all, because we're trying to slow the resistance of drug-resistant infection, the development of drug-resistant infection. So the chronic UTI people, patients who are fans of Dr. Paul Fugasato, who was the first doctor to really talk about this, who has now passed away, and now Dr. James Malone Lee. They are talking about using long-term antibiotics for a year or longer to try to deal with this chronic infection. Unfortunately, you're just not going to see the vast majority of urologists and hospitals who are focusing on antibiotic stewardship to support that. So it is a debate. They are at odds with each other. I see both sides. I absolutely think that there is a small population of patients who could have chronic bacterial infection. I believe that. But I also think they could have a fungal infection, and that needs to be ruled out too. And they could have a viral infection, and that needs to be ruled out too. I don't support broad strokes saying everybody has the same thing. It's not true. Just like a one treatment fits all approach does not work. Krista says, my specialist never really, ow, this is my knee again, never really gave me anything except to avoid or cut back on coffee, alcohol, said to try an elimination diet. I need more help than just a flyer given me. Do you know what I mean? Of course. Yeah, of course, hon. And ultimately, in the end, you've got to get that specialist focusing on your unique anatomy. You don't go in and say, I've been diagnosed with IC. You say, doctor, here are my symptoms. I cannot sleep through the night. I am peeing every 10 minutes. My pain feels like this. Do you have pain on the left side? Do you have pain on the right side? Is it low? Is it high? Is it external? Is it internal? Is there anything weird associated with that pain? Do you have shooting pain? Do you have a vibration, a buzzing sensation? Those are all important symptoms that you've got to share with that doctor as they try to understand your unique anatomy and what could be triggering those. Okay, so it's very hard to have an informed discussion about treatment options until we understand your anatomy, like what's going on with your pelvic floor, anything, or your muscles tight. Do you have positional symptoms? Do you have pain shooting down your leg? Do you have central sensitization? Do you have super sensitive skin like I do? Oh, it's so annoying. Like the back of my hand, my hand has been really sensitive because I had one little tiny thing on it that I got a couple days ago, and my whole hand has been just so annoyed. Sherry says, does anybody take buprenorphine sublingual tablets? I'm not getting much pain relief if I'm supposed to. I'm not, Sherry, I'm just not familiar with that med. Sorry. I'm not off the top of my head. Hey guys, hold on one sec. Let's take a quick bio break. It's been an hour. Anybody who needs to pee, go now. I'll be right back. All right, I'm back. Okay, note to self. Do not put Vicks Vapor Rub on and then go to the bathroom without washing your hands first. Otherwise, Vicks Vapor Rub ends up where it shouldn't be. And you're kind of going, oh, well, that's not good. Oh, dear God. Krista says, does IC affect eyes and stomach, or does the medication do it? They think it's just the medication, hun. There's no biological, pathophysiological connection between eye health and the bladder. There's nothing that they can. I mean, that was one of their questions, and the answer is no. Oh, here, hold on one second. All right, I'm back. Okay. I haven't been put on any medications yet, but my eyes and my stomach are getting worse, and I'm wondering if that's connected. Krista, any doubts? Seriously, go to your eye doctor. But a lot of genetics are at play with the eyes, and I've had 20/20 vision for years until about 5 years ago, when I had one eye go nearsighted and one eye go farsighted. Leave it to me to be special, right? And a lot of it has to do with genetics, but some of it also has to do with, I think we're massively overexposed to computer screens and stuff like that. I think that that's played a huge role in my eyes. But if you have any doubt, go to your eye doctor. Genetics matter. Lily says, I had a cystoscopy done to diagnose my IC. My mom fell on top of me, and 3 days later, I started with UTI issues, and I'm wondering if I'm misdiagnosed also. Well, again, anytime, Lily, anytime we ever see some sort of traumatic incident, like a fall or an accident, we're always going to look at the pelvic floor. Always, always, always. And so I would really want to know what the health of your pelvic floor is and is anything weird going on with your pelvic floor. Remember, patients get stuck in what I call the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. The reality is that they're both involved because they're so incredibly interconnected, but one is normally driving the other. So there's a group of patients whose symptoms begin with a bladder wall injury, like chemotherapy, and their bladder's screaming, right? And then their muscles get tight in a guarding reflex to protect it. So our therapeutic priority for that group of patients is to calm and soothe the bladder. When we calm and soothe the bladder, then we know that the muscles will release. But consider the opposite. What about the patient who has an entirely normal bladder, but they fall and they injure their muscles? So what happens to injured muscles is they become very weak, but they still have a job to do. So what happens is they have to overcompensate. So what happens to those weak muscles is they get super, super tight to do their job. And then unfortunately there's a legacy to tight muscles. And that is, what does it do? It's squeezing healthy tissue. It's driving blood away from healthy tissue. If you squeeze your arm really hard, you can see how it pushes the blood away. That's what happens to the bladder and the vulva and other structures in the pelvis when the muscles are tight. Those tight muscles are pushing blood away. So you're not getting good blood circulation. You're not getting good nutrition. You're not getting good oxygenation of those tissues because of diminished blood supply. Now, of course, you really have no idea that you've sustained any sort of injury at all. Your first symptom is frequency urgency. And you're like, okay, I must have infection. So you go to the doctor or you call the doctor, say, I think I have an infection. They throw you antibiotics and you don't get better. And you go back to the doctor. They might give you more antibiotics. Some patients have been on antibiotics for a decade and they never helped. Then you go back to the doctor when they don't work. And the doctor goes, oh, well, maybe you've got overactive bladder. So they give you ditrol or detrapan. Those don't work. You go back to the doctor. The doctor throws out IC. Maybe you got IC. They give you the diet and they give you Elmiron or GMSO, and those don't work. And the reality is, for this group of patients with tight muscles, none of those bladder therapies are going to work because their fundamental problem isn't their bladder. Their fundamental problem is poor circulation from tight muscles. Thus, our therapeutic priority for the pelvic floor patient is to restore blood flow. How do we do that? With pelvic floor physical therapy. When you do pelvic floor physical therapy and you release those muscles and you give that blood a chance to circulate, the bladder starts to heal again. What's that? That was a weird noise. Okay, so when they do, so think about it this way. So, so here's your pelvis. You left hip, right hip. You got muscles to go from left to right. You got muscles to go from front to back. You got muscles to go from low to high, right? It's kind of this spider web of muscles that support your organs. And unfortunately, the only way to assess these muscles is internally. I mean, when you go and you have a proper pelvic floor assessment, yes, they're going to look for muscle tension. They're going to have you walk down hallways. They're going to look for tension in your legs, in your butt, in your core, in your back. They're looking for weakness. They're looking for any sort of, body-wide muscle dysfunction, right? As well as back, whatever. But eventually they're going to need to do an internal exam because they need to touch these muscles. And when they do that, they're going to touch shallow muscles. They're going to touch mid-left muscles, and they're going to touch muscles that are a little bit deeper. But they can only go as long as their finger, right? So they can go in maybe 4 inches, 4 to 5 inches. I just had my last pelvic floor exam on Friday with my physical therapist Pam, who's wonderful. She's absolutely wonderful. And I got the all clear on Friday. She said, Jill, we fixed it. What was going on with me is gone, which is good, good, good. So how did we do that? We did that, number one. So again, so here's my pelvis. She had her finger in my vagina. And when we started, most of my dysfunction was deep. It was right around where my cervix was, where I had my surgical adhesions. And so we were doing pushing on the adhesions for a couple seconds and pushing away, doing this, right? And that turned out to be challenging. It was pretty painful. But it worked. And so eventually, then the deep muscles got better, the scar tissue got better, and most of my tension was shallow. And so she had me doing movements like this instead as I did my home care with my wand. Um, and kind of like in a J, right? Using your thumb and going kind of like, see it like that, right? Just along the shallow muscles for me personally. Um, and so there you go. Again, Chris Payne in his subtyping says that this is curable. Pelvic floor dysfunction is curable if you're willing to work with muscles. But some of you are very, very uncomfortable having somebody do internal work. But you got to understand that the only way to really access these muscles is internally. Another way to think about it is like this. If you've got muscles that are locked down, what they're going to do is very gently with their fingers, they're just going to try to work the length, right? It's about following the length of the muscle. And their goal here is just to try to get the muscle to its normal length. They don't want it tight, they want it right. So there's just kind of a lot of this going on. Or sometimes they will do this, they will go cross fiber like that. It's a really good book called Ending Female Pelvic Pain. Hey, you know it's not a support group meeting here in my office if something doesn't fall. Isa Herrera has written 2 fabulous books, Ending Male Pelvic Pain and Ending Female Pain. If you are a pelvic floor patient, you need to get one of these books. If you're a guy, you're going to get this one. If you're a girl, you're going to get this one. And it's just full of number one, it will teach you more about your pelvic floor and how it works in 5 minutes than any doctor could possibly teach you. I mean, I was pre-med and I did everything that I needed to do, and I learned a hell of a lot more from this book. But then there are lots of stretches and things, working on core. Like for me, ultimately in the end, it was about core work, that my core was weak, which was contributing to something else, which was contributing to something else. So you can get these books in our store. Jody just had a distension this week. Jody, how are you doing? Hope you're feeling better. Of course, the first couple days after a hydrodistension can be pretty uncomfortable, but things should calm down. Jody, if you notice that your symptoms feel like they've gotten worse, it's very common for patients to get a post-op infection after having a hydrodistension. So if you spike a fever, if your pain gets suddenly more intense or anything, call your doctor right away, okay? But hopefully that hasn't happened, and hopefully you're feeling better. And now the question is what they find. Susanna, Susanna writes, both my daughters and I have IC. We all 3 went to ophthalmologists to see if we had any eye issues related to Elmiron. 2 of us didn't and 1 did. She went off of it about 6 months ago. No change in symptoms. I think that was absolutely the best choice you could have made, Susan. I think that smart move. Heather says, I would like to see a study if it is the same for oral intake, which is systemic, or if it is instilled. Heather, do you mean with respect to eye damage or just with respect to bioavailability and effectiveness? Jody says, Elmiron was used in my distension this week, but she did give me some painkillers and I really didn't want to take them. And I did, and I got to sleep like I haven't slept in a long time. You know, pain medicine after hydrodistension is completely normal and appropriate. And I'm glad I personally would refuse to have it done without a prescription for pain meds, even if it's just 5 pills. I think having somebody go through a hydrodistension without pain care is really cruel. But so think about it this way. Let's think about the estrogen controversy for a moment. We know that when you take oral estrogen, that there's a significant risk of uterine cancer and or breast cancer. Why? Because when you take it by mouth, it's distributed throughout the body where it can arrive in the breast and in the uterus and cause issues. Whereas if you use topical estrogen is known for staying fairly confined to the tissue you put it on, which means, you know, if you put it on your vulva, it's known for staying there. That studies have shown that it carries much, much, much less risk of any cancer. And I think we can make that same correlation with Elmiron with respect to side effects. When you're taking Elmiron systemically, it is distributing throughout your body. Whereas if you're using Elmiron in a topical installation, you know, the bladder wall is what we call hydrophobic. Sorry, hydrophobic. So this is a three-dimensional picture of your bladder wall, right? So we've got your urothelium, and then we've got, your mucosal barrier, then your urothelium, and then your nerves and blood vessels and things like that. Hydrophobic means it repels fluid, it repels water. That's what makes the bladder such a good storage organ. And why it's so good at holding toxins is it's got this nice thick mucosal barrier that stuff doesn't get through. And one of the biggest challenges in delivering medication to the bladder is how do we get it through the mucosa deep into the tissue? And that's hard. That's hard to do. And that's where DMSO shines, because DMSO kind of opens up pathways for medication to pass through. Elmiron is not known for passing through the mucosal barrier to any great degree. And that is why this is a good slide. You can see this is an Elmiron slide, that the Elmiron kind of arrives on the surface of the bladder. They don't necessarily show it penetrating through. Hendria says, "Hi, Hendria. How does the body produce so much urine for us to urinate so often? Well, there can be some medical conditions that can produce and trigger excess urine and extra fluid. You might have something else going on. It could be thyroid issues, could be a pre-diabetes, something like that, which could potentially trigger more urine production. But IC in general does not trigger urine production. What IC does is, if you've got a bladder wall injury, what that means is that any fluid in your bladder is going to trigger symptoms. It could be 50 cc's of urine, or it could be 500 cc's of urine. Here, I've got some pictures, so let me show you. Hold on a sec. Let me find them. Okay. So let me show you, Hendria, let me show you two different types of pictures, okay? So this is these are 16 pictures of 16 different patients with Hunner's lesions. So Hunner's lesions are big bleeding wounds in the bladder. This is the perfect picture. It's known for what we call a stellate appearance, which means it looks like a star. There's a center, and then there are arms protruding from that center that are red. When you biopsy this, it's filled with inflammation. There's clearly a big fight going on there. And because inflammation is a sign that your body is at war with something. And of course, now we have research that shows that these patients might actually have viral infections. Okay. High viral load is found in patients with lesions. So imagine you've got this big wound, and as your bladder fills up with urine goes into the wound and triggers pain. And so as soon as that urine reaches that wound, you're going to start screaming. You're going to find a bathroom and pee. And as soon as you pee, you feel better, right? So Hunter's lesion patients have the most bladder wall sensitivity. But this is a picture of IC subtype 2 bladder wall driven. So this is more of a picture of an irritated bladder from some sort of chemical injury. So you can see it kind of looks like a road rash, right? Lots of little tiny wounds. So imagine having all these wounds in your bladder and then your bladder's filling with urine and all your urine is getting into these wounds. And so look at this picture. So look, urine now, there's a wound here. Urine is getting into these, and the wound might actually be deeper than this, and it's producing and exposing blood. Okay, so the fuller you get, the worse you feel, and it triggers pain. Sometimes severe pain because urine is going where it's not supposed to be into the wound. And then, of course, as soon as you pee, there's a profound sense of relief. So if you have pain as your bladder fills with urine that is relieved by urination, then that is clearly pointing to your bladder wall. If you have pain after you're done peeing, then that tells us that your bladder wall is probably pretty healthy and it's probably your pelvic floor. Jody says, I really believe that there isn't one cure for it. I hate the word cure. I hate the word cure because you can't cure a wound, you heal a wound. And that's where these subtypes really matter. What we would try to cure a disease, but we have to heal injuries or wounds or muscles, right? Julie says macular degeneration showed up for the first time in your last eye exam. So how long have you used Elmiron, Julie, or did you ever use it? Penny says, I would always try supplements before a prescription. Had good results with Sister Renew and pumpkin seed oil. Yeah, Sister Renew's out there. Absolutely. Cindy says, I didn't hear you talk about custody for installations. It has been, I don't know what you mean by that. Betty says she had great luck with Bladder Ease. Bladder Ease is another supplement, but it's not popular in the IC patient community, in part because one of the ingredients is derived from citrus bioflavonoids, Betty. So we don't normally suggest Bladder Ease, but if it's working for you, power to you. Cystostat. So Cystostat and Uracyst are two bladder installations that were never approved in the United States, but were approved in Canada and Europe. Cystostat is hyaluronic acid in liquid form that they install with a catheter into the bladder. Uracyst is liquid chondroitin. There's a really interesting story here because Cystostat was approved first, Uracyst was approved second. The only way United States patients could get it is if their doctor bought it from Canada. And the two companies, oh my God, they fought each other like mad. They wanted their market share. So they were constantly doing research to prove that their product was better than the other product. And then interestingly, somebody combined them. And when you combine the two, hyaluronic acid and chondroitin, and the name of the medication in Europe is called Ialuril, it's much more effective. So we don't see discussions of Cystostat. I think Cystostat was discontinued, actually. I think they both might have been discontinued, although Uracyst might still be around. I think Cystostat was discontinued because everybody's doing the combination of the two ingredients. And of course, it was Dr. Theoharides, when he invented Sister Protec about 20 years ago, who put hyaluronate and chondroitin in a supplement for the same effect. But of course, when you swallow it, you have to deal with bioavailability and stuff like that. But there are patients who don't want to be catheterized. They would prefer to take it by mouth. And so here it is. But it basically has the same issues that Elmiron has, in that part of it is going to be rendered inactive by digestion when you take it by mouth. Whereas if you put it all in the bladder, we know 100% of it arrives in the bladder. You just unfortunately pee it out. You can't hold it for 24 hours. You're going to pee it out quickly. Jeanette says, is there anything safe that is safe to take for a cold? Yeah, girl, come on. We did a huge little mini research study and article on this last year. That's over on our website. And let me see if I can find it for you. Cold and flu strategies for IC patients. I think we surveyed a couple hundred patients. So if you go over to the IC network and go under self-help, there's a section on colds and flu that has some really easy fundamental information in there. But then also, if you search our website for cold, flu, as an article called 2019 Cold and Flu Survey Results. And let me just get the link for that and I will post it in chat here. Of course, if I do that, then it's going to scroll and I'm going to miss questions. Oh, I don't want to do that yet. Just, hun, Jeanette, icnetwork.org. Just go over to our website and search for the word cold and you'll find it. The name of the article is 2019 Cold and Flu Survey Results, IC Friendly Tips and Strats. And we list the favorite sore throat products, the favorite OTC cough products, flavor of drops, favorite decongestion products. What do you turn to when you can't stop coughing? What's your favorite cold and flu strategy? What do you use to prevent colds and flu? What words of advice can you give to other IC patients struggling? It's this really long article. We also asked patients, did any cold and flu products give patients a flare? So there you go. Gina says, are they looking at ketamine infusions for central sensitization? I know ketamine abuse can cause ICs, so they're a risk when it's done they're a risk when it's done under the supervision of a doctor. My bladder is in remission after ketamine infusion around 5 days, 4 hours a day. Gina, that's absolutely fabulous. I don't think we have any research studies that really outline the protocol that you're using as well as the results. So I think it's absolutely fabulous. But as we know, ketamine cystitis is real. Patients who use and abuse ketamine or take ketamine in high amounts over time run the risk of really severe urinary tract damage, bladder damage, kidney damage. So there's that fine line between clinical effectiveness versus damage. Tamitha says, how do you prevent ulcers in the bladder? Well, I mean, there's still considerable debate about what's triggering ulcers. It's been one of the great mystery. Ulcers equal lesion, so we use the word ulcer and lesion interchangeably. So Hunner's ulcer, Hunner's lesion. It's been one of the great mysteries of the IC world in terms of why do lesions happen. We just had a discussion about this at the European Society of IC meeting last weekend. I was not there, but I was told about it. And where there's, well, let's see, was it? No, it wasn't there. It was in the year-end review of urology journals. Oh, here, hold on. Let me find it. Let me see if I can find it. Hold on. It wasn't at ESSEC. It was somewhere else. Hold on. Phil Hanno, the chairman of the AUA IC committee, wrote it. 2019 top stories in urology. Here it is. Okay. So Phil Hanno is the chairman of the urology committee for the American Urology Association. He has been deeply involved in all the federal studies for IC, the top spokesman for IC at these big conferences. and he is essentially the face of the IC world at the scientific level. And so he was asked what the top story in urology for 2019 was. And he says here, one of the major themes in bladder pain syndrome, and remember, we use IC and bladder pain syndrome interchangeably. One of the major themes of bladder pain syndrome literature this year is the ongoing discussion regarding how Hunner's lesions should be categorized. Is it a phenotype of bladder pain, thus part of the overall syndrome, or should it be set apart from bladder pain as a specific disease and thus a confusable disorder? It would certainly appear that Hunner's lesions have more in common with specific diseases that cause bladder pain rather than being simply part of a collection of symptoms that are given a name as a diagnosis of exclusion. Then he cites a study here. They conclude Hunner's lesions definitely an inflammatory disorder, whereas in bladder and patients without lesions, they don't find that inflammation. And there are few documented examples of patients ever converting between Hunner's and non-Hunner's. The Hunner's lesion subtype is characterized not only by distinct bladder histology, i.e., but specific clinical characteristics, reduced bladder capacity, favorable response to lesion targeted therapies, and etc. Okay. Okay, so getting back to your question, how do you prevent ulcers? Well, so prevailing thoughts is that Hunner's lesions is a separate disease process. Whereas people without Hunner's lesions have more of the syndrome. We've got other things that are involved. We think that Hunner's lesions is a disease. And what researchers in Europe have discovered is that patients with Hunner's lesions often have a high viral load in their urine. And they've now connected 2 viruses to lesions in research studies, Epstein-Barr from mononucleosis, as well as the polyoma BK virus, which is something we all have that just normally gets turned on if somebody's immune compromised. But we're also seeing, we've also seen discussion about HPV and herpes as well. So it's one of the great mysteries as to why lesions happen. We don't have absolute consensus. However, it does appear to be moving in the area of a viral infection. So the question is, how do you prevent viral infections? And if you've ever had mono, turns out the virus can arrive in the bladder. If you've been connected to HPV, we know that HPV can travel into those tissues and cause cancer. So I would say at a minimum, and I don't mean to push any political hot potatoes here, but having an HPV vaccine to prevent HPV cancer would be, I think, important. I wish I had a better answer for you. I just try to be as healthy as you can be. Eat a good, healthy diet. Stay away from fast food, junk food. I wouldn't be drinking coffee or energy drinks all day, every day. Be modest. Eat good, healthy, fresh food. Try to keep stress low because we know stress provokes inflammation. And I try to be as healthy as you can be. Lily says, how much is too much Prelief? Anything over the manufacturer's recommendations. They say 1 to 2 tablets before a meal. Heather says, I think there's a group of us that have multiple subtypes. Absolutely. I'm subtype 5, subtype 3. I've got central sensitization. That's my life. That's my foundation. I have a very sensitive body, but I also have a really significant muscle problem from SI dysfunction. Betty says, is there anything new that will prevent UTI from swimming? Going to Mexico with young grandkids, and I'm devastated that I can't swim with this. Well, so number one, it's all remember, gosh, how the hell do I answer that question? The Center for Disease Control issued a paper on the safety of hotel-driven swimming pools, and frankly, it was terrible. that like the worst place you can swim is in a hotel pool or a hotel hot tub or a hotel bathtub with jets, like a so um you know, if you want to, so what's the rule? The rule is, if you're going to swim, get out of the water as quickly as you can, take a shower as quickly as you can, don't sit in a wet bathing suit. You want to get out of that bathing suit as quickly as you can. You could drink, you could make sure you stay hydrated. You could do D-mannose ahead of time, maybe bring some D-mannose, which might prevent an E. coli based infection. um, I would just sunbathe on the side of the pool, to be quite honest, or sit on the side of the pool and put your legs in there, but maybe keeping your hips and your crotch above the water would be reasonable. I mean, the challenge here, I don't want to make any statements about pool safety and things like that in other countries and chemical knowledge and things like that, but you know, one of the things that we consistently see from Central America is people who have gone to hotels who have died. And they have been able to trace it back to, in some cases, pesticides that were put in the air conditioning system, toxic pesticides that have been banned. We also know there was another round of people who died. I don't remember what island it was, because somebody had put methanol, wood alcohol, into alcohol bottles to try to save money, and of course methanol is fatal. um, I would be, I'm very careful going to Hawaii, and that's in the United States. I have gotten very, very sick in Hawaii a couple of times, so would be extra safe. Rhonda says, what are your thoughts on axonics InterStim? I'm trying to gather info before it's time here. So we now have a new type of neuromodulation. So you guys know about InterStim. It's in step 4 of the IC treatment protocol. And InterStim uses a mild electrical impulse to kind of re-regulate the nerves. We actually have 2 forms of neuromodulation. We've got an ankle stimulation, which requires no surgery. The patients normally do first. I did that first, and it worked beautifully for me, and I didn't need to consider a more intensive surgical intervention like InterStim. So the challenge with InterStim is that they're implanting a lead in your back, and then down above your glutes, they're implanting a generator unit. And generator units have to be replaced because batteries run out. So a new company, Axonics, has created a new, smaller device where the battery lasts for 15 years. But it does have to be charged weekly. You charge it at home with some sort of unit that kind of, think cell phone, you're charging it up. You charge up your stimulator with Axonics. So I got an email from Ken Peters about it. We were talking about the eye stuff, and Ken Peters is in my opinion, the best InterStim surgeon in the world. And this is what he wrote to me 3 days ago. Axonics has some advantages over InterStim. The IPG is small, thus less discomfort at the IPG site. The battery lasts for 15 years, but needs to be recharged weekly. Most importantly, it is MRI safe, which has been a barrier with InterStim. And apparently, Medtronic is coming out with something called MicroStim in 2020, which will be even smaller and MRI safe. So that appears to be the trend. Hey, YouTube, I don't mean to be ignoring you. Let me go down to YouTube here. Hold on. I can always tell when I'm doing this if I don't have a really good night's sleep the night before. Words do not flow like they should flow. Diana on YouTube says, I have Hunter's lesions. If a viral infection is involved, can they identify the virus and get rid of it? Well, you can't get rid of viruses, hon. Once you've got a virus, you've got a virus. It lives on your nervous system. The question is it active or silent? So, for example, anybody who's had shingles, shingles is the virus that triggers chickenpox. And so normally we have chickenpox when we're young. And yes, the active outbreak of chickenpox goes away, but we always still have the chickenpox virus in our body. And there are moments when the chickenpox virus can get active and trigger shingles, which is it causes skin lesions. My sister just had an outbreak. My brother has had shingles on his back. My sister just had shingles on her arm. And it's like, oh, holy hell, please God, don't give me shingles. So Diana, you can't get rid of a virus once you have it. You're going to have it. The question is, can we stop the outbreak? You can viral infections can be identified with next generation urine testing. It's a specific test. If you go to bladderhealth.org, there are videos of doctors who use next generation urine testing to identify unusual bacterial infections or fungal infections. There's another level of next generation testing that they can use to identify any viral infections. And that's how they would do it. And then if they find viral infection that they think is pathogenic and active, they would probably give you an antiviral medicine, which they did for my sister for her shingles outbreak. And within a couple of days, it was massively better. So antivirals are real, but there's no research as yet on the use of antivirals with Hunter's lesions or anything like that. This is all very new, very cutting edge. And there's a lot of discussions about, I was really surprised that if you look at the European Society for IC guidelines, they specifically say rule out viral infections before you make a diagnosis of IC, but then they don't say how to treat them. And I emailed one of my contacts over there and say, okay, you rule them out, but how do you treat them? And they went, well, we don't really know. So there you go. Antivirals, lysine. Like if ever I feel like I'm getting a canker sore, I'm not prone to cold sores. It's rare that I get a cold sore. Knock on wood. Knock on wood. But I do get canker sores when I bite my lip, and whenever I get a canker sore, which is also the common herpes that most people have that drive canker sores, I chew up lysine. I get a lysine supplement and I chew it up if I feel any sort of tingling, and it works really well. I also use lysine chapstick if I'm feeling anything, and that also works really well. All right. So it looks like we have a nice discussion of vulvar flares going on. Donna, I hope you're feeling better. I hope they're getting to the bottom of it. Donna, I got to say, remember, I think I told you that I had this outbreak of vulvodynia last February, and it was very weird. I had vulvodynia when I was in my 20s for a couple of years. And to me, vulvodynia always felt like somebody had rubbed my vulva with sandpaper, right? It was a really awful sensation. And I hadn't really had any sort of major vulvodynia outbreak in decades. And then last February I had one, but it was very, very different. It was like little needle pricks along the outside of my vulva, along the hairline. It was like somebody was hitting me with needles. And they thought first it was yeast, but yeast medications didn't work. Then they thought it was eczema, but none of the anti-inflammatories worked, and the steroid creams didn't work. And finally, the pelvic pain specialist goes, Jill, that's a pudendal neuralgia. And I'm like, what? She goes, pins and needles. That means that you've got a nerve that is being compromised. And I went, I always associate pudendal neuralgia with kind of pain shooting down the leg. and pain was sitting, I would never think of it as a pins and needles sensation along the vulva. She sent me to physical therapy, and that's what fixed it. But they also gave me a compounded estrogen lidocaine jelly that worked really well too, as we just worked to calm that nerve down. And now the nerve is calmed down, and it's really rare that I have any pins and needles anymore down there. Amy says, uh, my urologist suspects that my frequency is possibly a neurological one. Neurologist ruled out MS, but he's very interested in the results of my recent biopsy of enlarged lymph nodes. Noticed at a routine mammogram. He said that if they would be looking at sarcoidosis, and the biopsy doctor said they would, in addition. Interesting. And we talk about that, Amy, in our fall magazine, when in my big article on the confusable conditions. Guys, this is the magazine of the IC Network. It's called the IC Optimist. Our fall issue was released before Thanksgiving. And there's a big article on confusable conditions, the things you want to rule out as you are trying to get to the bottom of your pain and discomfort. And one of these, Amy, is neurological issues. Neurogenic bladder. Yeah. Medical conditions that impair, reduce, or stop nerve function in the bladder can result in neurogenic bladder, including stroke, spinal injury, ALS, diabetes, alcoholism, B12 deficiency, herniated disc, Parkinson's, MS, and syphilis. Some patients have a flaccid hypotonic bladder where the volume of urine is large but contractions are missing, often occurring after spinal cord injury between S2 and S4. There may be improvement after a period of time. The dominant symptom is dribbling of urine and/or incontinence. Other patients struggle with a spasming bladder where the volume is quite low and involuntary bladder contractions occur. They too may struggle with urine leakage as well as urgency and incomplete emptying. This can occur from brain damage or spinal cord damage above T12. Still, other patients rotate between a flaccid and spasming bladder. This is often seen in MS and ALS patients, diabetes, brain, spinal cord turbos, and syphilis. What the heck is a turbo? I wrote it and I don't even know what that means. What? Okay. A diagnosis is based on a lack of bladder emptying as well as a variety of tests. A variety of therapies are available. So if you had a stroke, that can certainly affect your bladder and give you some neurogenic bladder symptoms. What does topical estrogen do for IC? If you've got IC, if you struggle with estrogen atrophy, if you've had a hysterectomy, or if you're of a certain age where you're perimenopausal or menopausal, you have to understand that this thick coating of mucus that protects your bladder wall is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus. When you're older and you have less estrogen, you have much less mucus. It's called estrogen atrophy. And as any woman of a certain age can attest to, things start drying out. You got dry mouth, dry vulva, dry vagina, and guess what? You can have dry urethra and dry bladder. And the urethra is kind of the canary in the coal mine here. The urethra is often the first part of the urinary tract to react to the loss of estrogen. Thus, it's the urethra that will start screaming first. You will feel like you've got a drop of urine stuck in your urethra. It will become very, very irritated. And so, what topical estrogen does, Kel, is it gives the body the chemical it needs to produce more mucus, estrogen. And so topical estrogen is the most important way that estrogen atrophy, or the genitourinary syndrome of menopause, is treated. Now, of course, we don't put estrogen in the bladder because we can't get it there. And so instead, it's used vaginally, and they believe that the estrogen kind of crosses tissues towards the bladder. But it's also often put at the entrance to the urethra, where it can help the urethra. That's what they had me do when I was going through it. Hendria, oh, Hendria, I'm sorry I didn't get to your question earlier. I feel spasms before I urinate. Does that signal something? Well, it depends upon the spasms. I mean, hold on a sec. Let me just look here real quick. You know, if you're having a hard, violent spasm where you're like bent over, it's like, oh my God, you can barely work because you're having a spasm. We often see that, and we often see that at the end of urination, not before urination, but that's a sign that your bladder is very, very, very inflamed. Or you can have a fasciculation. It's a really fine spasm. It's like a little buzz. If you feel a little buzz, like you're sitting on a cell phone on vibrate, that is often a muscle that's they call it a fasciculation that's spasming. Brock says, is the eye issue reversible? We don't know yet. Lisa says, I heard the EU is putting a label on the European equivalent of Elmiron. Are they put for the eye issue, Lisa? Dr. Jane thought something like that was going to happen. I haven't seen formal notice that that was happening. If you have a link to that, Lisa, could you send that to me? Kel says, if Prelief has calcium, what is a better supplement to use? Just went through a tough kidney stone removal embedded in the kidney and in the bladder wall. Oh, let me tell you, bladder stones embedded in the bladder wall are brutal. I am so sorry you've gone through that. Um, um, you might be able to get away with a little bit of sodium bicarbonate, you know, where you dissolve like a quarter teaspoon of sodium bicarbonate in a glass of water. That might be a better way to go. You know, when you have kidney stones, they want you to increase the acid, but of course, because that will potentially restrict crystal growth. But when you've got IC, we can't restrict the acid. We're trying to, because we can't increase the acid because that's going to irritate the bladder. So, Kel, man, you are in between a rock and a hard place here. I would, number one, make sure you're drinking plenty of water, follow the doctor's suggestions on what you can do for the kidney stones. If it's calcium oxalate kidney stones, you're going to have to reduce foods that are high in oxalates. We know that there's been a pretty dramatic increase in kidney stones because of the increase in almond milk. Uh, you know, a lot of people are doing a lot of almond milk. Almonds are very high in oxalate, so you got to remove oxalate high foods that could be contributing to it. And if your bladder's screaming, then a little bit of sodium bicarbonate would immediately alkalinize your urine. The question, Kel, though, is that you had stones embedded in your bladder wall. And I've worked with one other patient who had that, and he had like a mountain range of stones emerging from his bladder wall, just like this. It's crazy. I've got pictures of it. I mean, I think I think I even, I thought I printed it out. Huh. So sometimes when the bladder is extremely damaged, and in his case, he had so this patient who ironically just texted me, he was a victim of medical malpractice. And in fact, the urologist who treated him is in jail now. He had something very simple, not related to IC. The doctor did surgery, botched the surgery. His story is absolutely horrific. Not an IC patient, but what happened in the end is he had so many complications that they had to do God, what did they do? They had to remove his prostate. And when they removed his prostate, he started bleeding out, and his bladder filled up with blood and blood clots, and then it ruptured his bladder, and they had his bladder split in two. And when they surgically repaired that, wherever that incision was, grew out stones. And that's what happens when a calcium mechanism is damaged somehow by an extreme trauma. This is not an IC thing. IC patients do not get bladder stones growing out of their bladder wall. That is an extreme, normally some sort of extreme trauma type of situation, as it was with him. And so, yeah, they had to surgically remove them a few times before they finally stopped. And once all that tissue healed and that calcium mechanism was restored, then that bladder, embedded bladder stone emerging from his bladder wall stopped. I hope that kind of answered your question, kind of, sort of. I can't think of any other supplements. I mean, there's Calciblend, but they're all calcium based. There is a medication that can reduce acid levels too, and the name is on the tip of my tongue, and it will come to me eventually. Brock says, what medication options are available as alternatives to Elmiron and amitriptyline? You stopped taking Elmiron last year. When I became aware of the eye issue, still taking amitriptyline. Well, again, Brock, the alternative to Elmiron is really going to be the supplements that provide a bladder coating effect, or it's going to be using Elmiron as an installation, or heparin lidocaine installations. Those are your only options. With respect to the amitriptyline, amitriptyline calms nerves down. Taking a low dose antidepressant over time is believed to just kind of slowly but steadily calm nerves down. And so I think the nearest, I'm not aware of any supplement that is a match for amitriptyline. However, a supplement that you might want to consider that might help with a little bit with pain is Peora. Different mechanisms of action, but we did have our first palmitoethanolamide study with IC released in May at the AUA conference, where every single patient taking PEA resveratrol by month 6 had a significant reduction in their pain. So I think Peora might be interesting if you're taking it for pain control. Oh, hey, by the way, a friend of mine showed up about 15 minutes before this started. Do you guys know about peppermint M&Ms? Hold on. Oh, I chewed it up. Darn it. Hold on. M&M makes a white chocolate mint M&M for the holidays. Oh my God. So good. Let me cut it in half. See? It's white chocolate. So for those of you who miss your chocolate over the holidays, peppermint M&Ms with white chocolate are the bomb. Oh my God, they're so, so good. And speaking of good news, I have really good news. Look at this. It's here. Let me swallow first. Jill, don't stream with your mouth full. Oh my God. Sorry about that. Okay, I have swallowed, damn it. Oh, the sponsor is not going to be happy with me. Look what came. Oh my God, it's here. Wait. Okay. Do you know what this is? Guess what finally made it? The new low acid vitamin. It's called Bladder Smart. And it's better than Multirite. It's a cleaner, crisper formula. They ended up taking out quite a few of the minerals that some patients couldn't tolerate. And so I am, again, what do we know is that most IC patients cannot tolerate, oh my God, I'm so embarrassed. You cannot tolerate a multivitamin, anything with a lot of vitamin C in it or B6, because it's bladder irritating, right? right now there's only 3 low acid vitamins on the market. Multirite, which was my idea. I was meeting with FAR Laboratories about 15 years ago, and the CEO of FAR Laboratories said, "Jill, if you could make anything for an IC patient, what would you make?" And I went, "I know exactly what I'd make. I'd make a low acid vitamin." Because I was getting phone calls every day from patients who flared taking vitamins. We didn't have any vitamin. A couple weeks later, he called me back and he said, "Hey man, we've made your low acid vitamin. It was called Multirite at the time." But then, and Multirite has been out for a decade. Most patients tolerate it beautifully, except for patients with Hundred's lesions with a little bit more bladder damage. They might struggle with it, struggle with anything. But Multirite has been around for years. The challenge with Multirite is it's a big pill, number one. And number two, there were quite a few patients who couldn't use it because they had to restrict certain ingredients. And so I had been looking for another one. Desert Harvest Aloe came out with a low acid vitamin, but it's almost a match for match with Multirite. And it didn't really accomplish what I thought needed to be accomplished. So look, this is a brand new bottle of Bladder Smart. It hasn't been to you, and we're going to do it together. This is the first swing I've ever opened. Wow. Oh, it smells great. All right. So Multirite is a big old tablet that can get stuck in your mouth. This is going to be a really easy capsule to swallow. All right. And while the manufacturer is suggesting 3 a day, of course, for those of you who know me know that I come from a less is more perspective. Their recommended dose is 1 to 3 per day, but they're calling a serving 3. I personally think that multivitamins in general are massively overused because your body simply cannot use the vast majority of the vitamin you've just taken. You slough it off almost immediately. You start peeing it out within an hour, which is why your urine turns bright yellow. But there's one thing we do know about the IC patient community, and that is our diet's often very limited. And so if you feel that you're vitamin deficient, doing a low acid multivitamin is the way to go. And this is the one that we're going to be suggesting now. I think that this company is impeccable with their ingredients. This is Natural Approach to Nutrition, the same company that makes Bladder Builder and Bladder Rest and Pura. And it was one thing that I talked to them about a year ago. So this was put up on our website yesterday. And this is going to be our freebie today. I have got a box of this that I'm going to be giving away. So let's do it this way. I got 1, 2, 3, 4, 5, 6. The first 6 people who email me their mailing address is going to get a free bottle of this new low acid vitamin. And here's the email address. And don't just say you want it. You got to put your mailing address in there or you're going to lose it. So email me your mailing address to icnetwork@mac.com. icnetwork@mac.com. And the first 6 people who email me their mailing address are going to get a free bottle of this new low acid multivitamin. And I'll be very anxious to hear what you're thinking. People are already using it, but it's always nice to have something new to offer. I've been very unhappy with Multirite in the last couple of years. I just think it's too big, it's too clunky, it's too hard to swallow, and it's just got too much stuff in it. And so you doing a little bit of a cleaner formula is great. With this one, what they did is there's no B6 in it at all. So they took the B6 out, and the vitamin C is derived from calcium ascorbate. So if you go on over to IC Network website, icnetwork.org, click on the store, you can buy it. It's over in our store on the front page right now, but I am more than happy to pass out samples because I really want to hear what your thoughts are. I'm doing my stream. No, I can't do anything. I can't do anything. I'm sorry. All right. What is the rule? Do not eat and stream. I don't care. It's true with M&Ms. You cannot stop at one. Okay. I have to swallow. Oh my God, that is so good. This is why I buy a bag. I buy a bag and I eat half of it in the car and then I have to throw the rest of it away. So I'm not eating the whole bag. All right, guys. So we've got our winners. Alrighty. Let's get back to your questions. Lisa says, I'm completely new to this YouTube site. Is there anywhere these products are available? Yeah, they're all on the IC Network website, icnetwork.org. Just go into our store. Peaceful Abundance on YouTube says, I watched a video of yours where you talked about the symptoms and pain felt with each subtype. Can you please review as I can't find it? That video is called The 5 Subtypes of IC. So yeah, we can do that really quickly. IC subtype 1, Hunner's lesions. These patients often suffer with the worst pain, extreme pain as their bladder fills with urine because they've got a big old wound or wounds in their bladder, and they are extremely diet sensitive. So patients with Hunner's lesions are often reduced to eating, 5 or 6 foods. I mean, they tend to get very diet limited because the wound is so big, any urine hurts. Bladder wall driven symptoms are frequency, urgency, pressure. Pain as the bladder fills with urine that is relieved by urination. So the fuller you get, the worse you feel. As soon as you empty your bladder, you feel better. Some patients just have frequency, urgency. Some patients also have pain. And with respect to urgency, if you're running to the bathroom because you think you're going to leak and have an accident, that puts you in the overactive bladder neurological category. If you're running to the bathroom to reduce pain, that puts you in the bladder pain IC category. Pelvic floor patients can have frequency, urgency, pressure, pain, but they're not volume dependent. They're not volume dependent. If you've got Hunner's lesions or bladder wall, your day is focused on bathroom access because as soon as you hit fullness, you got to pee. So your day is very controlled by urine volume. Whereas if you've got pelvic floor, yeah, you're going to have frequency, urgency, but you're not going to have extreme highs and lows. It's going to be a steadier pain. It's going to be an achier pain. There tends to be a burning quality to it because muscles that are working hard are muscles that build up lactic acid. And many patients with pelvic floor, they have pain after they're done peeing. They have a spasm after they're done peeing as compared to before when they're done. IC subtype 4 is pudendal neuralgia. That's a nerve-driven pain. Their symptoms are very positional. They're fine when they stand, but when they sit, it hurts. When they bend over, it hurts. When muscles are tight, it's squeezing a nerve. So their symptoms tend to be very, very positional. Like I would have that pins and needles feeling on my vulva that I was explaining that related most often to sitting for a long period of time. And central sensitization is, you just have, you're sensitive everywhere. You've got sensitive skin, you got a sensitive stomach, you got a sensitive bowel, you got a sensitive rectum, you got a sensitive bladder. But anyway, there you go. Diana says, my brother is quadriplegic and uses a Foley catheter, so he has lots of UTI infections. Now he's resistant to many antibiotics. His doctor told him to use D-mannose now for his UTI infections. Well, D-mannose is a good preventative, but Allura. Allura is a very popular medication that many patients use who are prone to infections. It takes one of the active ingredients in cranberry, proanthocins, something like that. Um, Unfortunately, the problem with Allura is it's very expensive. However, the same company that has made this is making a new one called Prevent, PRVNT. And Diana, if you go over to a website called Natural Approach Nutrition, you can see Prevent over there. And so that would be, I think, the thing. That's the most exciting product that they're developing is Prevent. And then they also have a product called that's a biofilm buster, but it's related to for people who are hospitalized. So go over there, Diana. Prevent would be interesting. And I'm so sorry, but he's living proof that the more antibiotics you use, the more drug resistance can occur. Carolyn says, do you take topical estrogen forever? Uh, I intend to. I just have to say, I feel so much better when if I don't use my topical estrogen, my urethra within a week really starts screaming again. And so rubbing that little bit of topical estrogen into the entrance of the urethra is really beneficial for me personally. And you're just kind of between a rock and a hard place if you have any estrogen driven cancers where they don't want you to use a lot of estrogen. Then it would be something like using coconut oil or V Magic or any sort of organic lubricant that can at least give you a coating over those tissues so that they're not so irritated, especially if you have urine burn on your vulva. If you're peeing and your urine feels hot as it's passing your vulva, your urine is not hot. It's your vulva. Your vulva has estrogen atrophy and it's more vulnerable. And that's the classic sign that you would benefit from perhaps a coating that could cover up that skin so that it's not being triggered by whatever's in your urine and or giving it something like topical estrogen so that it can grow its own mucus. Buprenorphine is Sherry says buprenorphine is a generic for Belbuca, the go-to pain drugs in lieu of Norco. It's the new law to be weaned off hydrocodone unless you are a cancer patient or equal. Belbuca does not compare to hydrocodone. Sherry, I apologize. It's been such a big fall for me and so busy. I'm just not up on that. Now you've given me something to read about. Dagmara says, my IC is due to hormone imbalance. How do we fix that? What do I ask my doctor? I'm 38. Well, number one, you definitely want to have some hormone testing, see where your hormones are. There's definitely a subset of patients who are very hormone driven. That's subtype 2 bladder wall, where the bladder wall is very, very sensitive to changes in hormones. And that's why patients flare when they ovulate. Some patients flare when they ovulate, like I did, and they would flare a couple of days before their period. Normally, that's when estrogen levels are low, but people are different. So you could have your hormones tested and see where you are. But ultimately, like I was working with a patient who was 38. Actually, I don't, maybe it was you like last week or 2 weeks ago, whose mother had went through menopause in her early 40s, and she had all the symptoms of perimenopause at 38. She had anxiety, sudden moments of anxiety, sudden moments of crying, sudden moments of incredible anger, along with the start of dry skin and some mini hot flashes. So, if that's the case, you want to have a discussion with your doctor about maybe a short-term hormone replacement to get you through the worst of perimenopause, menopause. Sue says, have you ever encountered anyone with IC that had where IC was a bad side effect to another medication, and after stopping the medication, the IC went away? Yeah,
Yeah, definitely. There are some medications that are well known to trigger bladder wall damage. As you as an example, augmentin, which is a very very strong antibiotic, is really well known for irritating bladders at times. Also, yesterday, no. Last night, the chronic UTI groups produced a really good new video. I wish I could show it to you right now. Unfortunately, I just can't. And they were talking specifically about chronic infection and how it can go from outside and can start to infect some cells up here and kind of move its way down. One of the interesting factoids in that is they said that they thought it took 100 days for the cells at the bottom to make it to the top of the urothelium. I had heard at a National Institutes of Health lecture that when a urothelial cell is damaged, the stem cell underneath it took 2 weeks to grow, adapt, change shape, and fill in the spot. Um, I hadn't ever seen this 100 days for the low cells to get up to the top, and I think that's what it was. It's a great video. I think I shared it on my Twitter account. You guys, man, listen, I hope you're following me on Twitter, ICN Jill on Twitter. You can obviously follow us on YouTube. If you like these lectures, make sure these support group meetings that you like our Facebook page, subscribe to our YouTube channel, because that's how you get notified. A lot of these are drop in. We do 2 scheduled meetings a month, first and third Sunday, but I do a lot of drop ins too. Lily, I saw a new urologist who thinks I don't have IC based on cysto. He thinks I have some degree of pelvic floor and sensitive bladder. And since hormone changes are a big driver in my urinary symptoms, he think it might be a gynecological issue, possibly endometriosis. I started seeing an endo specialist and I'm going to have an MRI. I don't think you've been misdiagnosed, hon. I think that that's very, very interesting. And to me, that's very promising because he's willing to look outside the bladder. And the reality here is we know that endometriosis and IC have been called the evil twins because they are often linked together. And so working with an endometriosis specialist to see if you do have endo is absolutely the right thing to do. Rule it in, rule it out. And then they prescribe the Oralisa to cause pseudomenopause, which might alleviate your pelvic pain. If you've got endometriosis and you've got endometrial tissue in your pelvis, and endometrial tissue bleeds when you have your period, but obviously it's not inside your uterus, so it's not like it's going to come out of your body. What happens is blood pools in the abdominal cavity, and believe it or not, blood's not meant to be in the abdominal cavity. It's meant to be confined to veins and arteries. And so wherever that endometrial tissue is, it bleeds and it causes pain. So putting you into a menopause to stop your periods can help reduce that pain, but it's a big deal. It's a big deal. You have to really, Lily, you got to do a lot of reading about this. Make sure you understand the pros and cons of that medication. Make sure you spend a little bit of time reading about pseudomenopause and menopause so that you can be prepared for the symptoms, because you might notice, at least I noticed when I entered perimenopause, I had sudden moment. I would wake up anxious. I mean, we call it free floating anxiety. It's like I had no idea what I was anxious about. All I knew is I was really, really anxious. Oh, and I had some moments where it would just hit me suddenly, like I was out to lunch with my sister and my brother-in-law at my favorite restaurant, and right in the middle of it, I just wanted to run. I wasn't saying anything, but on the inside, I wanted to run out of that restaurant so bad. And it lasted about 15 minutes and then it went away. And it was a hormone swing. But I think the symptom which scared me the most was anger. I would just have sudden moments where I wanted to slug somebody. I mean, like be walking down the grocery store aisle, and I'd be just so angry all of a sudden. And I would ask myself, why am I angry? And I had no explanation for why I was angry. And I'm not a violent person, and I've never hit anyone except once when I was a kid, when I hit a girl who was messing with my horse. at the time. Um, um, but it scared me that I didn't understand why I was almost irrationally angry for 15 minutes at a time. And my OBGYN says, "Girl, you got the rages." And I'm like, "What's that?" And he goes, "If it walks like a duck and talks like a duck, it's a duck. You are perimenopausal. This is normal and it will pass." And it did indeed pass. It passed. That doesn't happen anymore. So, you got to be prepared for the fact that when they, Lily, when they change your hormones, you're probably going to go through some of those symptoms. So don't let them scare you. They're trying to accomplish something, but just learn about them so you can be prepared for them and maybe prepare the people around you in case you have moments where you get really angry or you just start crying. Let them know why. And that is they're messing with your hormones. Edith says, "Did I understand that you believe probiotics will help IC?" Well, Edith, what I can tell you is research studies continue to find that the biome, the urinary biome and the bowel biome in IC patients is not normal. And in fact, we just had another research study. Where was it? Did I put it in this magazine? Hold on. The National Institutes of Health certainly found that a national NIH funded study found that we were deficient in some important bacteria, specifically bacteria that nourish the cells lining the bowel. And we had an overabundance of some pathological bacteria. And so trying to recreate the correct the biome is important if it's off. Where is it? It's not in here. I did just read. Where was that? Where did I read? I just read that. Oh, it was at the ESSEC meeting. Oh, here, hold on. Let me go there. I stayed up till 3 in the morning several nights last week because they were tweeting from the ESSEC meeting in Amsterdam as the meeting was going on. And so I was watching it as they were tweeting the slides. So hold on. Let me see if I can find it. All right, here, hold on. If anybody wants to look at the slides from the ESSEC meeting, if you go to Twitter, search for hashtag ESSIC, ESSIC 2019. And a physical therapist from England, Jilly Bond, she's the one who was posting the slides from the conference. Oh, here it is. Okay, so urinary tract microbiome. No decisive pathogen or absence of benign bacteria explains the pathophysiology of IC, but microbiome alterations are correlated to BPS IC. What is the slide? They're talking about maybe subtyping based upon some bacterial findings. Hunter's lesions disease has different bacteria. And they think that tissue samples should be investigated for biome changes and the development of subtypes. But here we go. Long considered, people thought urine was sterile. Now we know that there are greater than 63 bacterial species identified in the urine of healthy subjects. Women tend to have an overabundance of lactobacillus and Gardnerella. Men tend to have an overabundance of Corynebacterium, Staphylococcus, and Streptococcus. And there are different microbiome compositions found in different diseases like overactive bladder as compared to bladder cancer as compared to IC. So, getting back to your question, can probiotics? I think probiotics make sense, especially in this population where we've been exposed to a lot of antibiotics. But I also believe in mixing it up. I don't think taking the same probiotic every day for years is the right thing to do because there is an abundance of different types. So I think mixing up your probiotics is fairly important. Cindy says they're still doing Cystastat in Canada. Okay, thanks for letting me know. I really thought I know I contacted the company because it was unavailable, and that was like last spring. So good to know that they've got it again. Rhonda, you'll have to ask your question again if I haven't answered it. Paige says she has shingles right now. Yeah. Kristen says, I just got a membership and need to know how to access the most recent issue. You just log into your member page. So you don't go to the main website, you go to our store, icnsales.com. You know, I practiced a divide and conquer philosophy with respect to security and cybersecurity. I don't have any payment information on our main website. I don't want any money traveling through our main website because it's a WordPress website and WordPress is constantly being attacked, and I pay a tush load of money to keep it safe. I keep our store over on the store manufacturer's servers. icnsales.com is our store. And so, Kristen, you log into your account over there. And as soon as you log into your account, your membership page will be the first link there. And if you've forgotten what your password is, you can do password recovery, or you can call me and I can reset it for you tomorrow or the next day. Penny says, say fasciculation fast 3 times. Fasciculation, fasciculation, fasciculation. It's hard. David says, if you were talking about the gentleman who had the bladder stones coming out of his bladder, it was, you know, let me tell you, he's become a very, very dear friend of mine. You know, sometimes, I mean, I love running the IC network and I love helping patients as much as I can. But, you know, it's physically impossible to answer everything. And so there are moments when I get emails from somebody that it's like I've got an angel on my shoulder saying, you need to stop and really help this person as much as you possibly can. And oftentimes I'll answer the phone on the weekends, even though we're closed, because it's just like something says this person really needs help. So I got an email from a gentleman who was really, really suffering, and there was just something about it that really touched me. And I wrote a really long, supportive email back, very, you know, filled with lots of tips and stuff like that. And he continues to say today, without that email, I would not be here. He says I saved his life that day by sending that email, and now he is an amazing man who's changed many lives and my life too. And I'm so glad that I could be there for him. And we're now good friends. That's the best part of IC, guys. I mean, seriously, the people you meet with IC teach you what real friendship should be. I have made more friends, really good friends through the IC community than I ever had before IC. And you guys are wonderful people. You're wonderful, wonderful men and women. And it's my honor to call so many of you friends, for sure. You are not alone. Christine says, what vitamins are in a Bladder Smart? The same vitamins, but they took out B6 and they used a low acid form of vitamin C. You can see the full list of ingredients over on the website with the label. Hi, Kim. Ravonda, I have ophthalmologist appointment this week. Last year, she checked for retinal damage and was okay. Should I be checked again? Hell yeah, you better be checked again, Ravonda, for sure. I would. David Bauman, can't find Bladder Smart. It's right on the front page, unless one of my team members removed it. Let me look. No, it's right on the front page. It's $27.50. Just go to icnsales.com, David. icnsales.com. I just put 100 in inventory, so I know they're there. Cindy says, where do I get Prevent? It hasn't been released yet, but it's getting very close to being released. So when it's available, you'll get it through us and or through the company. Is D3 or B12 one of them? Yes, it has D3 and B12 in it because those are bladder friendly. Anne says, is it normal for pelvic pain to just be on one side, always, almost all? Yeah, it can be. And so really what that points to, hun, is that points to something, a structure on your right side. If it were just a superficial bladder wall irritation, it would be centered to your body. The fact it's on your right side really points us to muscle. It points us to muscle, or it could be an ovarian cyst, or it could be a fibroid on that side, or whatever. You know, one of the things that you can do, and I don't know if I can do this. You know me, I always wear long things. So, okay, so look, here is the top of my legs, right? And then you've got your hip bones right here. So if you just push gently in right on the inside of your hip bone, see, look, that's my fat stomach because I ate carbs last night. And if you feel tension as you push in, if you feel a little bit of pain on the inside of your hip bones, or sometimes even right below your belly button, right in there, those are three kind of what's the right word? Signs of tight pelvic floor muscles. So when I push in, I had a little bit of pain on my left side, none on my right side. And that's because I have left side pelvic floor issue. So, you know, and you're the perfect example when I say to patients, do not walk in and say you've got IC. You're going to walk in and say, I have pain on my right side right here. And I'm trying to figure out what it is. This is what makes it better. This is what makes it worse. And your ability to describe that pain is going to play the central role in getting your doctor's attention and getting your doctor's care and the proper diagnostic workup. Lynn says shipping. You know what, you guys, I have first class deactivated right now, first class international for Canada deactivated in the store because it can take weeks and weeks to get through customs. But Lynn, if you call us, we can switch it out to first class for you. It's just such a bear shipping first class because it's not trackable and we can't tell you where it is. So what's happened over and over and over again, whenever we try to ship first class to England or to Europe or to Canada or to Australia, is after about 2 weeks, the customer goes, where is my product? I paid for my product. And my answer is, you got first class. There's no tracking. We can't tell you where your product is. And it's a literal slow boat. And so it can take anywhere from 2 weeks to a month, sometimes even longer to get there, sometimes first class, depending upon where it's going. Whereas with priority mail, it's trackable, you know, and you can track it in the system and we can track it in the system. But yeah, it's a hell of a lot more expensive and it sucks. And I'm sorry. We are working, Natural Approach Nutrition is actually trying to set up an affiliate in Canada to ship to Canadian patients. And when that happens, then you won't have to get it from the United States and it'll be much cheaper. We were just talking about that on Friday. So I do my best. I do my best. It's just, you know, we would often end up, 3 weeks later, the customer wouldn't get it. We'd give them a refund. They'd call us 2 days later. Yeah, it finally arrived. And then we've lost some money and it's a small business and we can't afford to lose that money all that time. I mean, I've had $300, $400, $500 orders lost. And it's just, you just can't absorb those losses all the time that first class international causes. I'm sorry, it just is what it is. But we're happy to try to send it to you first class. Mary Lynn, what, you're a horsewoman too? No, my sister was the horsewoman. I was a tennis player, so it was really my sister's horse. I was the barn girl. I could clean hooves like nobody's business. I could groom a horse like mad. But riding, yeah, no, I fell off. Anne says, I bet riding helps a lot with keeping your pelvis stronger. I used to ride. There's kind of mixed thoughts on that. I was working with a patient. She might even be in here. Yeah, okay. I don't want to say her name, but we had a patient who has been taking bladder medications for 30 years. Nothing ever really worked for her. They finally did an MRI, and they found a giant mass of scar tissue in her pelvic floor, right? And it was kind of woven around muscles. And they now think that it's this big piece of scar tissue that is causing all of her pain. And what made her so unique too is that whenever she tried pelvic floor physical therapy, it hurt terribly. And now we know why, because they were pushing on this big mass of scar tissue. So the question then is, well, did you have any trauma? And she was a mega horseback rider, and she fell off she had a couple of really bad falls, like right in that area on her tailbone. So it was probably, that which triggered this whole thing. Rebecca says Jilly Bond is amazing. She's really helped your pelvic floor. Hey, that's wonderful. She and I were tweeting. I was tweeting her constantly during the conference. I've never met her personally, but I'm really, really impressed. I'm really, really, really impressed with her. Angie says my really bad pain was on my left side. It ended up being scar tissue. Got that removed and much better, but I had pain. There you go. Jean says, hello, I went for my cystoscopy. I'm having so many symptoms. My bladder is healthy, so they discharged me. So why are you in so much pain, girl? Okay, so number one, this is really, really, really good news. Your bladder's healthy. So we have to move beyond your bladder. We have to look at other things that could be triggering your pain. And so and I just wrote a big thing on this. You are the perfect example of being an anatomical mystery to be solved. So now in all of your future appointments, you're the perfect example. You should not walk in and say you have IC. Your bladder wall is healthy. You need to walk in and say, I have these specific symptoms and I'm in a lot of pain, and we're trying to figure out why I'm in pain. But here's what we know. My cysto appears to be normal. And so you got to rule out a lot of stuff, girl. You got to rule out a lot of stuff. And in our latest magazine, I have this article, Confusable Conditions. Have you missed something? And you've got to really go through all of these other conditions, things like bladder neck obstruction, urinary retention, bladder stones, a urethral diverticulum, bacterial infection, fungal infection, viral infection, endometriosis, urogenital prolapse, fibroid tumors. Jean, if you want to call me next week, I'm happy to help you. Yeah, I'm happy to kind of walk you through some of this stuff, see if we can, create some questions for you to ask your doctor as you're trying to solve this mystery of your pelvic pain. Over on our website, icnetwork.org is our phone number. We have an 800 phone number. Feel free to call. Just know that I lost one of my phones in the fires and it hasn't been restored. So I'm down to one phone line for me personally. And so if you click extension 2 or extension 3, both of which go to my desk, the odds are you're going to get my message, because I just don't have the phone lines I used to have, and they got to figure it out. So just leave your name and number and I'll call you back, or with any luck, I'll be answering the phone and I'll work with you right then, hon. But I'd love to try to help you. The IC Network offers, we are the only nonprofit. I mean, I'm sorry, we're the only IC group because we're not a nonprofit. We're a health education company. We are a philanthropic for profit. What that means is 95% of what we do is free. And we have a free support line where you can talk to me and potentially other people about your IC. And if we can kind of guide you through some of the basics and give you some questions to ask your doctor or where to learn more about it, more than happy to do that. I'm on the phone virtually all day, every day, which means I'm getting way behind on my writing and my research that I need to do because so many people are calling. Um, but just know it's first come, first served. I often return phone calls late into the evening. And so if you're on the East Coast, you could get a phone call from me at 8 o'clock or even 9 o'clock because that's 5 o'clock or 6 o'clock for me. I can't do it any earlier than that because of the quantity of phone calls. And I can't return everything, but I try. But that said, we also offer wellness coaching. So if you wanted to spend an hour with me on the phone, going through your stuff, going through your history, you can sign up for that. That's paid, but you don't have to sign up for it. You're welcome to call. And if we've got the time, we'll work with you too, but it helps. And guys, if you find meetings like this helpful, we need your support. I mean, we definitely need your support to continue this. And the way you can support us is by becoming a member. Just $25 a year will give you this email address. I mean, we'll give you our magazines by email, and you can learn more about that on our website. But we can mail them to you. We have different memberships. Of course, if you buy stuff from us, that also helps us too. I mean, where else can you talk to a national expert for free? I mean, and we're happy to do that, but it's getting harder and harder because so many more people are being diagnosed. I can only be spread so thin. And ultimately, in the end, I'm doing a lot of research too, and leading the Elmiron eye stuff with the FDA. So my life is really, really full right now. But again, sometimes angels sit right here and say, "You got to talk to this person," and so I do. I try to whenever possible. All right, all right, all right. We've been going for about 3 hours. 3 hours. I wish you a Merry Christmas. I wish you a Merry Christmas. I wish you a Merry Christmas and a Happy New Year. Last call for questions. Last call for questions. Good tidings we bring to you and your kin. Good tidings at Christmas and a Happy New Year. I've never had figgy pudding. Last call for questions. Last call for questions. I see you, YouTube. Last call for questions on YouTube, too. All right. So, okay. So, man, let's put our heads together here for a moment. So, what are we now? We are 10 days away from the big day. I don't know about you, but I love all of Christmas until like 2 days before when the stress hits big time. So, my intention here is to breathe a lot, to take time, to go slowly. I want to, and that's what I wish for you. I don't want you to feel overwhelmed about the holidays. You don't. It does not. There's nothing perfect about the holidays. And think about it this way. Think about it this way. You go back to your favorite holiday memories. None of them are planned. No, they're the spontaneous things that happen that make the holidays truly special. Whether it's the spontaneous snowfall or snow fight or my grandmother making weevil soup, because she put old noodles in it. And oh my God, my cousin looks at her bowl of soup and sees insects floating in it and goes, "What's this?" everybody looks closer at their holiday soup and it's filled with weevils. And that's a hysterical memory. And my grandmother right now up in heaven is looking down at me going, "Jill, you do not have to tell that story." And she didn't just do it once, she did it twice. She did it a week later. So, be receptive to the funny things. It doesn't listen, if you can't go to your favorite Christmas service or concert, that's fine. stream your favorite music at home. It's okay if you miss it once. It's okay if you say no because you're in pain. That's not going to ruin Christmas. You're going to feel better because you're not pushing yourself, right? It's okay to say no. It's okay to bring Christmas to you. It's okay to sleep in. It's okay to show up late. It's okay to say, I can't do Christmas morning, but I'll come for dinner. It's okay to bring your own food. It's okay to stay at home. It's okay to do what you need to do for you. For you. Don't sacrifice your body to make other people happy right now. You're no different than someone who is hit by a car. If you need help, ask for it. If you need somebody to help you wrap presents, ask for it. If you still haven't ordered presents, I'm telling you, this is the perfect year for gift cards. You can do Amazon gift cards. It doesn't have to be perfect. It just has to be sweet and happy. And I want you to have a sweet and happy holiday. Now, in the meantime, let's think about this for a moment. Let's think about this for a moment. This is not the time, this is absolutely not the time to go crazy bad with your diet. Okay, now seriously, you do have Prelief. Where did I put my Prelief? Bring a bottle of Prelief wherever you go. And if you don't want to disappoint grandma by not eating her whatever she's made that you know could kill your bladder, perfect time to do Prelief, right? So let's plan a little bit. Again, bring your own food. If you need to, bring your own food. But the cool thing is that the typical holiday foods are very, very icy friendly. So for us, for Christmas Eve, we used to do lasagna. We do not do, and it was just too rich. It just made us nauseous. It wasn't just a bladder thing. It just made us sick. Now for Christmas Eve, I usually do a pot roast. I cook a crock pot meal, like a crock pot meal with beef, potatoes, carrots, mushrooms, gold, not irritating at all. And then for dessert, we're always gonna have some sort of special dessert. So pick your Christmas Eve meal, something that's not provocative. So if you gotta go somewhere else the next day, your bladder's gonna be fine. And then, like one of the things that I had to learn, because especially in the first couple of years for me when driving was painful, it's not so painful anymore. People would always say, are you going to come, are you going to come, are you going to come? And I'm like, I'm going to try, and they're like, but we need to know. And I'm like, I can't tell you. I took all the emotion out of it because I didn't want to disappoint anyone. And so what I said to every single one is, I'm going to see how I feel that morning. And if my pain is a 4 or below, I am on my way. If my pain is above a 4, I am going to stay home for me. And it's true that when everybody goes to holiday dinner at your sister's house, your aunt's house, your grandmother's house, and you're at home and you watch them drive away, you're going to cry. I cried. But you know what, man? I went and got my nightgown. I mean, I would be dressed and ready to go. Makeup on, hair curled, ready to go. And it's just like, I can't do this. I can't do this. And of course, my mother, the master of the guilt, would like, honey, you're all dressed. Don't you want to come? It's like, no, can't do it. I'm going to ruin it for everybody. And I'm going to stay home with my heating pad. And there's something so great about taking your clothes off, putting your flannel robe on, getting your heating pad, getting your hot cup of whatever it is you're drinking, taking whatever medicine you need to do, which for me was normally an antispasmodic, and going and sitting in front of the TV and turning on a movie. And I would just say, you know what, if you can bring some food home, that's great. Gold. I cannot begin to tell you how much better that made my holidays. Now, in the last 26 years, I've probably done that 5 times. Just 5 times. But it was everything. And the last time I did it was when I was going through menopause and I just started having terrible cramps. And like I'm laying in the fetal position, like 15 minutes before we're supposed to leave for Christmas Eve. I was just dying. It's like, oh my God. And I was just laying with my heating pad on the couch, fully dressed. My older brother comes in. He's like looking at me going, yeah, what's wrong now? It's like, oh, I'm having cramps. He goes, Jill, come on, we're going to dinner. Get up. It's like, I said, Jack, hey man, because he's Jack, I'm Jill. We're both redheads. Yeah, my parents had a sense of humor naming us. Yeah, they did. Like, Jack, you're going to have to take him. I'm staying here. And they left, and I took my pain medicine and I laid there, and it took about 3 hours for the pain to stop. So, okay. So what I'm trying to say here is it's okay to stay home if you need to stay home. Um, again, the way I started this meeting today is it's important that you walk in, not with your heart on your sleeve. You've got nothing to defend yourself. I don't want you to be defensive about anything. You haven't done anything wrong. This is not your fault. You're hurt. And if anybody tries to give you, you know what, drown them in facts. And honestly, you know what I would do is I would say, I was just attending a lecture and they talked about something called the subtypes of IC. Let me tell you about that so that you can understand this a little bit more. IC subtype 1, Hunner's lesions. These are big bloody wounds. IC subtype 2, and they're probably viral. IC subtype 2, bladder wall driven. Drown them in facts, drown them in information. And you know what? I did I think 2 meetings ago, I'm wearing a green holiday shirt. Um, if they're like, yeah, right, turn it on. Put them in front of your computer or your cell phone. Have them watch the first 30 minutes. I give them a talking to, a holiday talking to, right? So bring in facts. And if you can, seriously, bring them our magazine, hand it to them. Say, look, here's a list of confusable diseases. This is what we had to rule out to try to figure this out. Or look, this is what it was. All this time we thought it was my bladder. It was never my freaking bladder. It was a fibroid tumor, right? That'll give you credibility. You are an agent of knowledge. You are an agent of change. And you know what? One of the greatest gifts of IC, because there are gifts in every situation we face, right? One of the greatest gifts of IC is the gift of compassion, because you will never, ever, 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 ever walk away from someone in pain anymore, right? Because you know what it's like to be alone and in pain. If you have a family member that's in pain, you will be there for them. If you have a family member who's broken their leg right before Christmas and they're staying home, you're going to their house. You're going to help them. The greatest gift is compassion. And Kevin Hart, you guys know the comedian Kevin Hart, right? Kevin Hart, who hysterical comedian, been in a lot of movies, and he was in that big car accident in Hollywood, several months ago, and he got this terrible back injury. And it's 3-4 months later now, and he just appeared on a couple of talk shows, like he was on Jimmy Kimmel, and they asked him about it, and he said, and I thought it was such a profound moment. He said, after back surgery, he could do nothing. He could not even wipe his what. He could not move. He needed help for everything. He was in the hospital for 9 days, and then he went home, where his family had to do everything for him, including very intimate things that he could never imagine that they would do for him, including, his son and his wife. And he came to realize, and he said this, he said, it's not about the money. It's not about the car. It's not about the house. It's none of that. What it's about is having somebody who will be there and help you when you cannot help yourself, right? And that's the gift of facing a major illness or injury like this, is all the things that you thought were important, the fancy shoes, whatever, the fancy car, going out, having a $50,000 wedding. None of that's important. None of that is important. What is important is knowing in the face of adversity, you have somebody who will be by your side and help you. And that's the gift of facing an adversity is all of a sudden you change how everything you look at. All of a sudden, the car doesn't matter. Give me an old beater, I'm fine. A truly rich life is a life of love and a family who cares for you and family who will be there for you. And that is truly what I wish for you, what I absolutely wish for you this holiday season. You are a good person. You have done nothing wrong. There is no shame. There is no blame. And I truly wish the best that life has to offer for you, but you're on a journey right now. And the journey is to try to figure out what the hell is triggering this pain for you. What is your anatomical mystery? Christine says, are you going to announce the winners? God, look at you guys. All right. So the winners of the vitamin are okay. You know what? I have to decide if I'm gonna give away 6 or if I'm gonna give away 8. 2, 4. I can't give away the one I just opened, obviously. Okay, so I've got 8. I've got 9. So I'm going to tell you the first 6 that got it, but I might give away more. Okay. So Lisa White, Paige Horn, Sherry Diggs, Angie Cook, Allison Acton, Kristen Kramer, David Bauman, you're a possibly Jackie Tatch, you're a maybe also. Okay. So you guys were the ones who got through the quickest. Alrighty. I know, Jack and Jill, that's hilarious. You want to be it. You can imagine growing up on the phone you call home and you're on a back in the days when we had pay phones. Hi, Jack, it's Jill. Everybody around me were like, yeah, what? And we look like twins. If you could see us, we look like twins. The only difference is that he has rosacea that I used to have, but I treated it with a cream that went away where he refused to treat it. So his skin is really messed up. Although it's looking better, he's finally doing stuff about it. Penny says, the stress of family often sets flares off for me. I try every year to stay calm and zen. Sometimes it works, sometimes not. This year I'm determined. Merry Christmas to you all. Anybody see the new Katy Perry video for her new Christmas song? I love it. I love it. I think it's hysterical. I want to be the girl, the lady who's got her hair piled up on her head with ornaments in it, and she's sitting at the counter and she's shooting eggnog, and she's going, yeah, right. And she's in an eggnog drinking contest with Rudolph the Red-Nosed Reindeer. It's hysterical. All right, my friends. I'm going to do another chat this week for sure. And so I will see you in a couple of days. I'm not sure what time, depends on how the schedule goes. All right. So I wish you a Merry Christmas. I wish you a Merry Christmas. I wish you a Merry Christmas and a Happy New Year. I'll see you in a bit. See you later, guys. I love to sing. Go figure. Well, I'm trying to shut the stream down on Facebook. All right. Goodbye, Facebook. All right, YouTube. Holy moly. All right, you guys. Be well. I'll see you later. Lisa, it was nice talking to you earlier. I'll keep you in my prayers. You're making progress, girl. You're definitely making progress. That is a good sign. Donna, I wish you the best. Carolyn, Iris, you guys, Becky, Kel, Diana, Amy, Hendria, Peaceful, Brock, you guys. I'll see you later.